We are live.
Thank you. A very good morning to each and everybody looking into it. So from AOS, we have the GuruSangam 2025 to 2026 edition with Educate, Elevate, and Excel. And here we are for session 8, which is again glaucoma. And on auspicious Sunday on December 7th, we are going to have a 3-hour masterclass of teaching. And we thank the AOS Governing Council, the President, Secretary, and Treasurer, Partha Sir, Santosh Anavar Sir, Manoj Mathur Sir, and the whole AOS team for this wonderful initiative of Guru Sangam. And we are lined up with star-studded speakers and panel for today with Dr. Shalini Mohan ma'am from GSVM Medical College, Kanpur. Dr. Anindya Anuradha ma'am from Manipal Hospital, Ranchi, and Dr. Pooja Hingorani Bang ma'am from AIMS, Nagpur, and Dr. Tutul Chakravarti ma'am from Eye and Glaucoma Care, Kolkata. So, welcome, dear speakers. And also, we are lined up with a dynamic expert panel. Dr. Deventuli sir from Narang Eye Institute, New Delhi. Dr. Devendra Sood sir from Max Panchil, New Delhi, and Dr. Mona Kurana ma'am from Shankara Netralaya, Chennai, Dr. Subhashini Kaliyaperumal ma'am from Jipma, Pondicherry, and we have Dr. Swati ma'am from Arvind Hospital, Pondicherry. Welcome to all the esteemed speaker and the panel. And I'm Dr. Prasanna Venkatesh Ramesh going through the faculty introduction. After this, we'll be having the tonometry masterclass by Dr. Shalini Mohan ma'am, followed by gonioscopy. Is it really difficult? And then we'll be having the scotoma from blind spots to visual defects, followed by the types of glaucomatous visual field defects. For these are the skeleton aligned for today. So myself, along with the co-moderator, Dr. Sunandini, who's from Bhagat Hospital, New Delhi, will be moderating the session. And with that, I think let's start the day. I'm handing it back to the first speaker, Dr. Shalini Mohan ma'am. Welcome you, ma'am, once again, and looking forward.
Thank you.
Thank you. Thank you, ma'am. Looking forward to hearing from you on tonometry. Over to you, ma'am.
Thank you so much, Dr. Prasanna. And thank you to All India Ophthalmic Society for this opportunity to talk about tonometry. My presentation seen?
Yes, ma'am. It's visible, ma'am.
Is my presentation visible?
Yeah, visible and moving also, ma'am. Yeah.
So, tonometry, great. So we all know and understand that tonometry is basically the measurement of intraocular pressure. So the ideal method to measure intraocular pressure is by manometer, but we cannot cannulate every eye every time. It is risky also, and therefore we have instruments for measurement of intraocular pressure, which are known as tonometer. So why is it important? It is important because intraocular pressure is the most important risk factor for glaucoma management. For glaucoma, reduction of IOP is the mainstream strategy for glaucoma management. Large fluctuation in intraocular pressure, which is circadian rhythm, is important because it has role in optic nerve damage and also in glaucoma progression. Moreover, diurnal IOP monitoring is important in assisting diagnosis and also in management of glaucoma. So it is clinical measurement of intraocular pressure by deforming the globe and correlating this force responsible for deformation of pressure within the eye. So there are two basic principles, indentation and applanation. In indentation, as the name suggests, we indent the cornea, and therefore, because the cornea is depressed in that particular area, and therefore the displaced amount of fluid is more. Whereas in applanation, we flatten the cornea. So because of flattening, there is minimal displacement of fluid and therefore it is more reliable. So in applanation tonometry, we have two types of tonometry. One is constant force, which is Mackay-Clock tonometer, and then we have Goldman applanation tonometer, where the area which is pressed is constant. So this is the prototype of Mackay-Clock tonometer, in which the area of applanation is measured, that how much area has been applanated by this device. And then this is the chart where this area is correlated with the amount of applanated area, and accordingly the pressure is assessed. In Goldman tonometry, which is the gold standard and was introduced in 1867 by Sir Goldman, this is the prototype of Goldman tonometer, which is based on Imberg-Fick's principle. In an ideal dry thin wall sphere, the pressure inside the sphere equals the force necessary to flatten its surface divided by the area of flattening. Now, because the area of flattening is kept constant and therefore pressure equals to force. So here the diameter of external area which is applanated is 3.06 millimeter, and at this diameter, whenever the force that is applied is multiplied by 10, it can be converted into intraocular pressure. And as I said, because of minimal displacement of fluid, it is unaffected by ocular rigidity and therefore more reliable. So let's see the basic structure of the applanation tonometer. This is the housing. Then this is the feeler arm, on the top of which we have this biprism. Now, whenever we see this biprism, its role is to half the circle into two semicircle like this. And here, under the cobalt blue light, when we stain it, the tear film, with the help of fluorescein dye, we see two semicircles, the inner margin of which should meet. Then this is the adjustment knob. Let's have a closer look here. Now we need to rotate this so that the two inner margin of the circle, they meet and start pulsating. And at this point, if we see that there is this 3 reading, we multiply it with 10 and get the intraocular pressure readings of 30. Now, let's see the procedure in short. We have to explain the patient, make the patient comfortable, yourself comfortable, put Paracaine eye drops, put adequate amount of dye in both the eyes, and explain the procedure properly to patient. Whatever extra fluid and dye is there, wipe it nicely so that you have much. So first, keep the prism near the eye, look from outside first and then look into the slit lamp uniocularly and start seeing the Myers. Rotate the knob so that you see that the inner margin have met and are pulsating, and that is the point where you have to take the reading. But before taking the reading, withdraw your instrument from the patient's eye, away from the patient eye, and then start reading. So here, if it is 1, that means intraocular pressure is 10. This is just to have a closer look of the prism and the fluorescein strip. So these are the various types of Myers which you might get whenever you are dealing with the patient. Here you can see they are quite away from each other. So this happens in high intraocular pressure. In the second picture, we can see that they are quite inside to each other. This is low intraocular pressure, and this is exactly the correct point where we need to measure. So these are variety of types of Myers which we tend to get but are not always correct. In the first picture, we can see the lower half is larger, which is not right. In the second picture, we can see the lower half is smaller and it is out of the prism. The upper one is higher. So in fourth picture, we can see there is lots of dye which should be wiped off. In the this picture, we can see that the thinner Myers are there and the readings will not be accurate. And in the last picture, we can see again too much amount of dye, you will get high readings of intraocular pressure. So these are all not correct, and therefore we should have adequate amount of dye to get a adequate amount of Myers, and they should be meeting nicely. Advantages are that there are extensive publications on validity, reliability, reproducibility, and repeatability of Goldman applanation tonometer, and therefore this is the gold standard. But then, because we require topical anesthesia, it is a contact procedure, so there is risk of infection. As I said, amount of dye assessment is important, and therefore experienced technician is very, very important. We need to make the patient sit, and we require sit and therefore lying down posture examinations are not possible. And of course, it is affected by corneal biomechanics and central corneal thickness. Now coming to indentation tonometry, which was introduced in 1905 by Sir Shiotz. Now here the principle is to indent the cornea. So the plunger will indent a softer cornea more than the harder eye, and this is the basis of Shiot's tonometer. Here, displacement of a set volume of fluid is there, which is represented by movement of a lever along the measuring scale, and is proportional to the pressure inside the eye. So just a quick look on various parts of Shiot's. This is the handle by which we hold the instrument. Then this is the foot plate which rests onto the surface of cornea, the plunger which moves freely within the shaft in the foot plate, the bent lever which where here it rests over the measuring scale. Now we can see this measuring scale on which we have to check of 5.5 milligram, which is incorporated in the Shiot's tonometer, and we have additional weight of 7.5 and 10 grams, which can be incorporated in case the readings are higher. So we have this conversion table, which is Frenwald nomogram. We need to assess that what are the various markings and how much is the pressure on the basis of this chart. So the question is that if Shiot's is not too reliable, does it has any role today in today's practice? But then advantages are it is a user-friendly instrument. It can be used both by residents and optometrists. It is portable and affordable. But the problem, as I said, it is affected by scleral rigidity. It has got Moses effect, but it has been seen that it is because it is very user friendly. Therefore, in many of the peripheral areas, it is still being used. So for screening of patients, and then we can corroborate our readings with applanation tonometer in case of doubt. Now coming to an important issue, which is reducing the risk of cross-infection. So we have to avoid tonometer tip needs to be cleaned with 70% isopropyl alcohol swab and allow it to dry nicely. It is effective for HIV and other organisms. Soak tonometer tip in 1% sodium hypochlorite solution for maximum of 10 minutes and then wash it thoroughly because it is toxic for corneal endothelium. Epithelium. Now coming to cleaning of Shiot's tonometer. Now in Shiot's tonometer, it is important. Now here you can see this is the barrel, this is the plunger. We need to remove it and clean it nicely. Because if you don't do it, it sticks and then the tonometers gets useless. So remove the plunger and use gauze with alcohol to clean the plunger tip. Clean the inside of the barrel with an alcohol-soaked cotton tip and then dry it thoroughly. Clean also the foot plate. That should be cleaned thoroughly with the alcohol and allow it to dry. There are a variety of other types of tonometer which are available. Let's see them, which are important to us, especially the non-contact tonometry or the air puff tonometry, which uses a rapid air pulse to applanate the surface of cornea. So IOP is estimated by detecting the force of the air jet at the instance of applanation. So it is fast, simple, and non-contact. It is used for screening of individuals or non-compliant patients and avoids transmission of infection. The advantages are there are no topical anesthesia is required, no fluorescein dye is required, and no direct contact is with the cornea. It is quick and can be performed by paramedics also. But we need to have caution whenever we are using non-contact tonometer. Take average of at least 3 readings. Confirm your findings with Goldman applanation tonometer. It is more influenced by central corneal thickness than GAT, and therefore we need to be careful. Never start treatment on the basis of NCT readings, and it is unreliable in cases of children, non-compliant patients, corneal disorders, and keratoplasty. Now coming to another two handheld tonometers, which are Perkins and Draggers. So Perkins tonometer, we can see is an applanation tonometer. It has got a biprism, and it is very, very good, especially in pediatric patients or the patients in whom you have to do intraocular pressure in lying down procedure. Now here in Draggers tonometer, there is a different biprism. It is electric motor driven, but not that commonly used nowadays. So we have another very important tonometer, which is Mackey Mark type of tonometer. Now in this, the principle involves combining applanation and indentation with a pressure sensitive transducer. Here there is a foot plate with a central and free floating plunger that measures the force exerted by the eye pressure. So because it is free floating in air, so pneumotonometer is the prototype. So here it records initial reading by flattening the cornea against the foot plate, but then it applanates it and actually isolates the true IOP. So pneumotonometer is being used at few of the centers, but this should not be confused with air puff or the non-contact tonometer. It is especially useful in cases of eyes, irregular corneas, or edematous cornea because endpoint doesn't depend on evaluation of light reflex sensitive to optical irregularity like in Goldman applanation tonometer. So the tonopen is the prototype of Mackey Mark type of tonometer, which is widely available nowadays. It is a handheld tonometer and it correlates nicely with Goldman tonometry. So here the topical anesthetic drops are required. There is a tip that covers and that can be changed in between the patients. There is a small contact area and can be used in irregular corneas. It has got reliable measurements even on therapeutic contact lenses and therefore commonly used. But then it has certain disadvantages as compared to Goldman applanation tonometer. It can underestimate the intraocular pressure at lower values. It overestimates at higher GAT values, and it is also influenced by central corneal thickness values. Now coming to other handheld tonometers, which is this one is extremely important, which is the rebound tonometer. It is extremely light with disposable probe. It makes a fleeting contact and spring back action and based on the principles of indentation. It is very, very comfortable, can be used in all the postures and anesthetic is not required. And it has got good correlation with Goldman applanation tonometer, more reliable than non-contact tonometer. But then there are disadvantages. It is influenced by central corneal thickness, where it obtains higher IOP than GAT, especially in thicker corneas. Disposable probes are required. But rebound tonometer is an extremely good device to be used commonly. Now coming to certain newer tonometers which are there, which are less affected by corneal biomechanical properties, in which Pascal dynamic contour tonometer, then we have ocular risk based on Schimflug analysis principle. So when we talk about DCT, it is a slit lamp mounted device, just like applanation tonometer. It is designed to measure intraocular pressure independent of corneal rigidity or thickness. So it is based on the principle of contour matching instead of applanation. So here we have this kind of concave tonometer tip that matches with the corneal curvature. And therefore, this is the DCT probe that rests on the relaxed cornea. It has a piezoelectric sensor that measures intraocular pressure at least 100 times per second. So advantages are it is very repeatable and reproducible. It has intraocular pressure which is measured. It is slightly higher than GAD, but it is very, very useful in patients after keratoplasty and refractive surgery because it is less affected by the corneal properties. But it has certain disadvantages. Of course, it is a contact device. The training of staff is very, very important because it is not that easy device to measure intraocular pressure. So, and patient cooperation is required and it is time consuming also. Now coming to ocular response analyzer. Now here, rapid air impulse applies force to the cornea and uses an electro-optical system to monitor this deformation of cornea. So the device records two applanation events. First, while the cornea is moving forward, inside, and then when the cornea comes outside, it again records the reading. So corneal biomechanical response to rapid indentation by an air jet, it is known as corneal hysteresis. So now here let's see that here we can see that this is the air pump, which is this is the light emitter, and here we can see this is the receiver. So air jet comes over to the cornea and starts flattening the cornea. So at the point where it flattens the cornea to the applanation level, at that point the applanation pressure is recorded. So we can see the flattening of the cornea, and at which point the pressure is recorded. This is the applanation while the cornea has gone in. At this point, the receiver has recorded the signal peak, and then again the cornea comes outside, rebounds back, and at that time the second applanation pressure is recorded. So it is a dynamic bidirectional applanation. And here in this chart we can see this is the in signal peak and this is the second peak. So this difference in the applanation value equals to the corneal hysteresis, which is a measure of viscoelastic dampening of cornea. So low hysteresis is associated with progression of glaucoma, and measurement of IOP is independent of corneal biomechanical properties in this particular tonometer, which is recorded as IOP cornea compensated, IOP CC. So the advantage is that it is less influenced by the corneal properties. It measures corneal hysteresis and corneal resistance factor. Patients with lower CCT and lower CS values, they have higher IOP CCC, and therefore the stable values within different daytime measurements which were independent from IOP fluctuation detected by GAD can be measured by ocular response analyzer. It is repeatable and it is a non-contact device. Therefore, this has its own advantage. So, but there are disadvantages. It provides higher IOP as compared to GAD. It is less repeatable, more reproducible, and also relatively expensive device, and therefore not that commonly used and not available widely. Now coming to Corvus ST. Now it is again a novel device. Here again air jet is there, which uses an indentation system and uses ultra high speed Schaumburg technology to measure the intraocular pressure by corneal deformation response. Advantages are good repeatability and reproducibility. It has got good, is again non-contact in nature, and in vivo monitoring of corneal properties can be done by Corvus ST tonometer. The disadvantage is again cost pretty high. Lack of widespread use is present, and training is also required for the staff. And we need a table mount of setup, and therefore can be used only in sitting posture. Now coming to another subset of tonometers which are used for home tonometry. So this is a diaton tonometer which measures the intraocular pressure through the eyelids. The important thing is that because no contact is involved, no anesthetic drop is required, and there is no risk of infection. So it calculates the pressure by measuring the response of a free falling rod. It is based on the Newton's second law, and as it rebounds against the tarsal plate of the eyelid, here you can see the display over which the readings are there. So it is safe, quick, efficient, painless, and non-invasive. Can be used in children and adults. So here we can see how the measurements are being taken by diaton tonometry. Another one is ProView eye pressure monitor. Now it is used by patients at home they press the device against their partially closed eyelids until they start seeing the phosphene. And the force used to create this phenomena correlates with the intraocular pressure. But there are significant discrepancies with this device and therefore not that commonly used. Another handheld self-tonometer is Occitan S tonometer, which is used after applying topical anesthesia. Patient holds in front of their eye and the prism touches directly into the cornea. There is again a digital display here where we can see how much is the intraocular pressure, but they have that comparable to Goldman applanation tonometer. Now coming to diurnal variation, we understand that there in intraocular pressure, circadian rhythm is there, and we have fluctuating intraocular pressure throughout the day and night, and therefore measuring throughout 24 hours is important. Now, in case where there is academic institutions are not there, where 24 IOP or IOP monitoring cannot be done, we can do split diurnal variation or office diurnal variation, where we measure intraocular pressure at different times of day in several days, say 1 or 2 days. We call the patient at different times and then we can measure the intraocular pressure. Now, but sometimes we need to measure with regards to 24 hours day. So for that 24 IOP monitoring, we have this contact lens mounted device, which is known as Triggerfish Silver, which here exact intraocular pressure is not measured, but there are IOP fluctuations which are measured in the form of graph by the brain gauge, and there is this wireless antenna. Now, signal from this signal antenna is directly correlated to intraocular pressure, but this is not the actual intraocular pressure. So, to summarize, I would say that Goldman applanation tonometer is still the gold standard. There are non-contact devices which are available, and the newer devices, they are more reliable also, and therefore reducing the risk of infections and corneal aberration. Now, the anesthetic is not required in many of these devices, but specialized training is needed. Now, rebound tonometer is useful in many of the screening purposes as well in clinic. The devices that allow you intraocular pressure measurement in supine position, like tonopen and perking tonometers, are helpful for the patients which cannot sit upright. The newer models of rebound tonometer, they can also be measured intraocular pressure in lying down or supine position. ORA, DCT, and Corvus ST, they are promising device, but they need further studies and they also need to reduce their pricing if for wider use. So important is to pick your own purpose. Like very young children or supine position, you can use tonopen, Perkins, or rebound tonometer. For screening, you can use non-contact tonometer, which is the air puff tonometer. For CAMS, a portable device is good, like tonopen and RT. For glaucoma patients, Goldman applanation tonometer is the only predictable and reproducible tonometer which should be used in all glaucoma patients. Thank you so much.
Thank you. Thank you, Shalini ma'am, for the extensive masterclass. Opening the session to the panelist, Dr. Devenduli sir, your comments.
So I think it was actually a masterclass, as you said, and Shalini always does this for all of us at AIOS. So thank you, Shalini, for that. Just wanted to ask you, in a teaching hospital like yours, which are the tonometers that you actually have?
So we have applanation tonometer, two of them at least in OPD, and then we have a Shiod, so NCT handheld we have. And rest of the tonometers like Corvus and all those, the fancy tonometers, we don't have.
No, that's okay, because I think you take care of the masses in central UP.
Yes.
So I think that's a very important thing, that you at least have applanation for, if not all, for the glaucoma clinic or for the glaucoma situations. And the second thing is, how do you actually have facility to admit the patient for TV?
Yes. Because we are government setup, we have academic institution, we have residents backup also. So we do admit patients for 24-hour IOP monitoring. Although overnight IOP measurement becomes a challenge, because if we are doing on applanation, it is not available in wards, and there SHIORD is available. So we make it early morning diurnal variation until late night diurnal variation checkups
And you know, this Guru Sangam program
every
is so
3 hours.
popular. It's so popular, Guru Sangam is that a large number of private practitioners are also watching this. So how do you suggest to them for an
So
office
as I
dial?
said, we can do office dialer or split diurnal, in which we can call patients, say, early morning in a day, and then afternoon, and then in evening and late night. So in a span of 2 to 3 days, we can complete this kind of pressure checkup, and then we can compile all the reports and can assess that what exactly is happening to the pressure of patient.
So I think that's important. If the practitioners don't have admission facility, they should not do away with the concept of variation of pressure. It has to be done as suggested by Shalini. And the last question I have for you, and then the other panelists can chip in, is about. No, I think let the others do, because I've taken a lot of time. Go ahead, Prasanna, to the
Yes,
other
sir.
panelists.
Yes, sir. Dr. Devendra Sood, sir, your comments, sir.
So I think that's a very good talk. I just like to re-emphasize that sometimes we are so busy measuring the intraocular pressure, two things become important. One is calibration of the instrument. And the second thing is to disinfect the tonometer prisms. Whichever tonometer is being used, whether it's an applanation tonometer, the tip needs to be cleaned appropriately before every use. Even a non-contact tonometer, that way is truly not non-contact. So we need to be very careful and keep this in mind. And remember that if we have patient with red eyes, discharge, known conjunctivitis, we need to be a little cautious. Very good, wholesome presentation.
Thank you. Thank you, sir.
Yes, sir.
Mona, ma'am, your comments, ma'am.
I think ma'am is not available. We have the next.
Dr. Subhashni, ma'am, your comments, ma'am. Ma'am, you're on mute.
Hello, everyone. Dr. Shalini did a very comprehensive presentation, and it should be really useful for the PGs, covering all aspects. But one thing I would like to say regarding the SHIOTs, nowadays we discourage using SHIOTs. So now we have better tonometers. I think we need to encourage residents and private practitioners to use more of the Goldman applanation tonometer, because the accuracy, two things we look for, whether it's accurate and precise. So accuracy is how close it is to the true intraocular pressure. So that we achieve with the Goldman applanation. And precise is the reliability and the consistency. So that is also achievable to a large extent with Goldman. And regarding the ocular response analyzer, it is available as compared to the DCT. DCT is not available in India, but ORA, I think Apasami is a supplier, and we do have a Reshirt machine. The Corvus ST actually does not give a value for the corneal hysteresis. So though in the refractive surgery setup, it's mainly useful, the Corvus ST. That is it. Like I think now people have moved on to rebound tonometers, even in adults. So this is more frequently used. The IC200 is the instrument that can be used in the supine position. And I think Dr. Swati can throw some light on the home tonometer, the IC400. She has used it in her patients. So that is it.
Thank you, ma'am. Swati, ma'am, over to you.
Thank you, Prasanna. Thank you, AIOC, for giving me this opportunity, and happy to be part of this panel. So good presentation, very nice presentation, Shalini. It was like a revision for me.
Thank you.
So yeah, short tonometer. After Corona, actually everybody has stopped. I mean, we stopped long back in Arvind. But yes, the PG should know what is a short tonometer, because they should know the first thing which came in our hands, like when we were PGs. So they should not be surprised, oh, what is the short tonometer? Patient has to look up like this and fix on the. So they should know, but then they have to move on. They have to practice the Goldman perfectly. And rebound tonometer, as madam said, yes, it is the go-to choice for most of the private practitioners now. And we had a home tonometer also. So that was like kind of it's like a handheld device where the patient marks on the cheek and the forehead and puts like this, and it is a rebound tonometer only. It works on indentation, and so we gave this tonometer for patients to do diurnal at home, so they can do in the night also. So 12 o'clock in the night, 2 o'clock, 4 a.m., 6 a.m. and 8 a.m. And then they used to return back after a week's reading. And in normal tension glaucoma patients, actually we saw a fluctuation of tremendous fluctuation in the night. So which we used to feel, there is something, some ocular perfusion pressure, but actually we saw it with the home tonometer. So that is expensive, but we can have some given on rent. So I think that's a good option rather than shorts or diurnal IOP. And rebound tonometer also, the tip, we use one tip for 10 patients and then we keep it. And then we put it in hypochlorite, sodium hypochlorite, and then again one tip for 10 patients. And then after 5 something, then we discard it. So it depends upon how your institute is using the tips, because they're quite expensive and we autoclave them. So, but yes, the accuracy goes on decreasing as the tips become old. So this is my take. Thank you.
Thank you, Swati ma'am. Mona ma'am, your comments, ma'am.
Thank you. Sorry, my internet is a little slow in between. So yeah, it was a very beautiful presentation. Very exhaustively, Dr. Shalini has covered tonometry and taking the pressure off from everybody. So I'd just like to add to what Dr. Sood also said about the calibration. That it's very important to calibrate the tonometer, and it's very easy. Your Goldman tonometer, usually there's a rod available. If you don't have it, you can do it without the rod at the 0 point, which you can actually do every day yourself. Without that, your readings do become meaningless. Second is about the cleaning of the tip, and make sure once you clean the tip, you wait for some time. Otherwise, you'll end up causing a map on the cornea of the patient. So make sure it's nice and dry, whatever solution you're using, and then put it. And basically, multiple readings also, Dr. Shalini has highlighted that you don't need to go by one reading, go by multiple readings either on the same day or different days, and correlate clinically. So clean, calibrate, correlate the tonometer. And additionally, the CCT, earlier we had CCT nomograms, but based on the World Glaucoma Association guidelines, we don't correct the reading by CCT, we just interpret it in terms of the corneal thickness, whether it's a thin, thick, or an average thickness cornea. So that's my points for the PGs.
Thank you.
Prasanna, can I
yes.
just button
Please,
if there's any
yeah.
any other panelists left though?
No, sir. We are done with the panel.
So we have two outstanding moderators today, Sunandini and Prasanna. So let's not forget their comments. So Prasanna, I have a question for you. Knowing how good an innovator you are, what have you for us in AIOS on the horizon? What is new from your side on tonometry?
Sir, tonometry front, I am personally not innovated anything in tonometry, but I think going forward, if we are able to get the contact lens tonometry or something that
So that is what I had in mind. If
yes, sir.
you can work on something like that, which is a cheaper
nano
version of what was available from the MNC, and that will be great for the Indian masses.
Something that
Thank you.
really amazes me as a protocol or as an idea is, can we get the reading measurement from within the eye? Because direct manometry was something that was always valued as a tool that you get the reading that is exactly inside the eye, but due to invasive reasons, it's something that we can't do. But if we are able to innovate something with nanotechnology or maybe an IOL which can actually be inside the eye and give the readings, I think going forward that may be the future, sir. Maybe a decade
I'm
from
very
now.
sure in the next 2 years we'll have a PV tonometer.
You're kind, sir. Thank you.
I think you can go ahead with the next.
I'll hand it over to Dr. Sunandini, my co-moderator, to moderate the next set. To you, Sunandini.
Thank you. Thank you so much, Dr. Prasanna. So with this lovely panel discussion of tonometry, we now move on to our next speaker, Dr. Anandya Anuradha ma'am, who is going to speak on gonioscopy. Is it really difficult? Over to
Happy
you,
morning,
ma'am.
everyone. Am I audible clearly? My
Yes,
audio
ma'am.
is clear. Thank you
Yes,
so
ma'am.
much. So thank you, AIOS. Thank you, GuruSangam team, for giving me this opportunity to present this topic. Gonioscopy, is it really difficult? Is my screen is now visible?
Yes, ma'am, it's visible.
Yeah, it's in slideshow, right?
Yeah.
Okay, perfect. Sure, thank you. So actually, my presentation is going to focus on the second part. Is it really difficult? And why I'm going to present the second part of this topic is because of this study. That's in 2024, they have published in Indian International Journal of Ophthalmology. The topic is ophthalmic examination and ophthalmology residents subspecialty preference. So what they have done, they have taken all the possible eye examination that usually the resident doctors during their PG post-graduation ophthalmology, they go through this, they learn this. And after that, they are doing this study to identify which uh, examination they are finding it difficult, because at the end they are getting the result, the thing that they are getting difficult, they're actually avoiding in their future specialization to take or to go for it further. So on this top they got its gonioscopy. So that's why I have chosen this topic, because I go through a lot of videos, teachings focusing on gonioscopy, but after that also, if our residents are finding it difficult, so I have tried to focus on that part, okay, how we can overcome that difficulty in this session. So just to understand the gonioscope that we are using in the OPD, it's actually indirect gonioscope, and it's not a gonio lens, it's a gonio mirror. But that we use in the surgery, like what is known as a direct gonioscope, that is a gonio prism. So because we are seeing through a mirror, so obviously the reflection, total internal reflection, and it's all detail about the physics. I'm again not going into that physics, but just coming to understand what is the indirect gonioscope, what is direct gonioscope, and these are actually gonio mirror and gonio prism. What is the difference? Okay. So now that we have spoken on, that whatever video and teachings are especially focused on types of gonio lenses, and what is the grading of the angle, and how the grading is different, what are the types of grading available, and what are the findings you will see in the angle, how to differentiate. So all the gonioscopy teachings are actually directed towards that. However, we have never tried to focus on the challenges that the residents go through. So that's why in the general ophthalmology practice, we found that they are actually uncomfortable in doing routine gonioscopy. So these are the various type of gonioscopes, and you can use anyone as per the availability and your own comfort. So once you put the gonio lens, this is how it is visible for the superior, inferior, and temporal, and nasal. So here I will like to say that in gonioscopy, because it's a mirror, if you are seeing the superior mirror, that means actually you are seeing the inferior angle. And if you are seeing, then the vice versa, if you are seeing the inferior mirror, that means you are actually seeing the superior angle. And when you are seeing the nasal mirror, that means you are seeing the temporal angle, and the vice versa for the temporal mirror and nasal angle. But it's not like 90°. That means if you are seeing something superior left, means it is actually inferior right. But it's because that's a lens, it's like that. But because it's a mirror, so if you are seeing something superior right, that means it's actually inferior right. If something you are seeing say nasal mirror superior, that means it is actually the temporal angle superior, right? So the superior and inferior, it's not going to change in the nasal and temporal mirrors. And the same thing for the inferior and the superior mirror. It's not going to change whether you are nasal, that means it will be, temporal. It's not like that. If it's temporal, it's temporal. If it's nasal for superior and inferior mirrors. So that should be this location. You should be careful, because if you'll mark the location properly, suppose you saw a iridodialysis, a foreign body, anything, so your location marking has to be correct. So this is how it looks like in a 4 mirror, in a 3 mirror. So in the center, you will see the cornea. You have to go to the mirror to see the angle. You are not supposed to see the center and try to find out where is your angle. Your angles are only visible in the mirror. So your slit has to move to the mirror. Okay, so with consent, I have taken a video of my first year resident who is being with me for last 8 months. So she has seen me doing gonioscopy, day and night. So obviously all kind of gonioscopes are available with her, direct, indirect, every types. So and every kind of gonioscope she has seen. So I have taken one video with her consent, what she goes through while doing the gonioscopy, where she fails, where she finds difficulty. So if by chance you are one of them, you are at that stage, so that you will come to know, okay, it's something very common. Everybody goes through that, and it's something that you will overcome over time. So the patient here it's taken is an optometrist. So obviously he is aware about the complete examination process. And if you see, his eyes are, a little bit protruded, well exposed. It's not a deep-seated eye. So very cooperative patient. And already in GuruSangam, the communication, how you will explain the procedure, how you make the patient comfortable is already told. So we are not going into it. So our patient is absolutely cooperative. And is the audio audible? Is the audio audible?
No, it's not heard.
Okay, fine. Then I'm just explaining. So she's right now going for the 4 mirror gonioscope, because that's the kind of the most common gonioscope that should be used. That should be ideally used, because it doesn't use the coupling fluid, and we can see whether the angle is on indentation, it's opening. So that means we can differentiate whether it's a appositional angle closure, whether it's a synechial angle closure. And it's the we don't have to rotate the lens. So that's why the 4 mirror is considered as the ideal lens to be used. And that's why she is being given the 4 mirror for the to start with first. So I will be showing you, once she will go through that, what are the difficulties she will be facing. So from the beginning, she is trying to make sure that the lens is in place outside. Then now we focus key what she is actually seeing. If we'll see very carefully, the red one that is visible inferiorly here. So is my mark is visible, that when I am moving the crusher, is it seen? Is the pointer visible?
Yes.
Yes,
Yes.
So
ma'am.
this
Yes, ma'am.
red portion is actually eyelid. This black portion is the the cornea part. You can see the pupil here, but she is not able to appreciate that she is actually on the lid. Now she's trying to, okay, I am not focused, but it's not actually, it's the focus. Her placement is wrong. So this is the lid margin. These are the eyelashes. So she, every time, she is saying, I'm not able to focus. I'm not able to focus. She's not actually in the place. So, that's the difficulty she's getting. So gradually she's even coming down further. She's trying to search where I'm going to focus. She is not sure where is the lens is actually. Okay, now she has lost the cornea completely. She is completely on the eyelid. So we will go for the next one. Okay, so now this is the, 3-mirror gonioscope that is given. So you have the coupling fluid now. So once the coupling fluid is there, so it is easier to hold. So once you are in place, you will be there until you really deform the eyeball or the patient will squeeze the eye. So that coupling fluid having the rim, it will create a negative pressure. So that's why the holding will be more longer in comparison to 4-mirror, where it can move as per your hand movement very easily. Okay, so now the 3-mirror is placed, and now what she is seeing actually, let's focus. So now she is, see the amount of light. She has focused exactly on the pupil. Once you will focus this, see the amount of brightness he is using. If that kind of brightness will be used, and obviously the patient is going to be very much hesitant, they will not continue with the procedure. So you should be using only that light and not on the center of the pupil, very dim light to start with. And now, okay, she is focused on the lens, but again, I'm moving my cursor here. See, the eyelid margin is now visible. Please check for the eyelid margin. So what happened? Because the eyelashes eyelid margin is here, now she has trapped the air. It's not that the visco is less. Visco was adequate, but because she has placed it on the eyelid margin, so there is a place so that the visco is out now. So the visco is minimal, so she got the air bubble because of that. When she started, there was no air bubble. I had personally cross-checked, no air bubble in the visco. But once you place, see the eyelid, it's now prominently visible. So now she is able to identify, okay, eyelid is visible. So she is trying to, okay, pull the eyelid down and again trying to place it. But because now the visco is out, so see the big air bubble. So if you really want to avoid the air bubble, first learn just to place it. Ask the patient to look up and then place on the sclera. Be quick to place it in the eyeball. Never bring the eyelid within the coupling fluid, this lens, because once the eyelid will be there, the it cannot catch the 360 degree of the limbus. So that's why there will be definitely a visco loss. Now she is thinking, she is trying to see the angle. See, this is what she is thinking. Okay, I am in the angle. I'm now trying to, see the angle. Actually, she is on the cornea only. She is not moving to the mirror yet. And now she is searching where is the angle. Even, she is thinking, okay, this rim is the angle. So this is her thought process that, most of them then they'll go through. So then the second, next third one, how she will be. Now she is given a 2-mirror, the smallest gonio mirror. So now see that with the 2-mirror, just on the same time it is taken. It's on the same day, same moment. So 4-mirror, 3-mirror. Now see how. See, she is doing a very wrong insertion. It should be the inferior eyelid that has to be. Yes, now she is going for the inferior eyelid. See, pull it down. So now she is inside. So easily, no struggle at all. So with the coupling fluid is already there. The viscoelastic is there. Directly, okay, no eyelids. So she is there. So this scratch marks, that means she is on the surface of the gonio lens now. So if you see this kind of scratch mark, that means you are, this, you have to move further. You have to focus further to go and see the cornea first in the center. So see, now she is on the cornea and the pupil, the crypts are visible. That means she is okay. Now she is moving towards the mirror. Correct. So she is now, understood I have to move towards the mirror. So this is the superior mirror. That means she is actually seeing the inferior angle. So in the superior mirror, see, notice she is not able to focus the angle, but anyhow, she can see this is the angle. That's fine. If you have seen this much, give party to all your colleagues. It's good enough to start. And I'll say, this also comes after 4-5 trials. So it's not that in the first go you will be there. Just, insert And yes, this is what, she is seeing in the superior, mirror. And now she is trying to move, going down. So make sure when you will rotate your joystick, it should not be to the extreme, because you should have the ability to move up and down and sideways. So now she has gone to the inferior mirror to see the superior angle. Now it's because it's a two mirror, now she has to learn rotation. It's a 90-degree rotation, because now you see superior, inferior. Now she'll go for nasal temporal. But because she has inserted the lens perfectly, the coupling fluid is there, the negative pressure is there, patient is not squeezing because the patient is comfortable with a smaller lens. So the rotation is not really difficult. Now she has rotated in the same hand. No one has helped her. So now you see, she is able to go to the nasal side and seeing the temporal one, going for the temporal and seeing the nasal part of the angle. So, okay. So what I asked her that, you please help me. You ask few questions too, because she's a DNB student, so has contact all over, they have a group of DNB students all over India. So I asked, please go through the questions that, what are the common difficulty that our PG students go through for gonioscopy. Then only if we'll understand the difficulty, then we can address it to the target. So let's go through one by one, and let's go through what is the solution for that. So the first thing, what they say, accessibility to gonio lens. There are PG institutes where they don't have gonio lens, or the gonio lens is there and it is kept very nicely locked under key, and it's available to the consultants only, and PG students are not allowed to handle, because obviously if there will be any loss, replacement will be very difficult. Then to PG students, I'll definitely say, for my own personal experience from my residency, please purchase gonio lens in your first year of residency only. If by chance you find it's economically challengeable to do that, you can make a group of your, all the residents, purchase one gonio lens, give lens to one resident, weekly, like Monday to someone, Tuesday to someone, and that person should be keeping the lens in the pocket of the, white coat, or on the top of your, slit lamp, so that it is easily accessible to the residents. Now come to the second point. Choosing the right gonio lens to begin with, we have already discussed. If you are purchasing, please purchase a 2-mirror gonioscope, so that from the very beginning, it should not, hamper your confidence. If the confidence is gone, we can't help you. Then come to the third. Choosing the right patient, cooperative patient, for beginner is always a blessing. But I will say, don't choose a patient. Choose your own residents, your own colleagues, because when you go through, like, you are a demo patient, your another resident is doing on you, and when you go through that pain, how discomfort it is for a beginner is doing on your eye, then you will develop that empathy towards patient. You will not go too long, too far. You are not going to press too much. You will be just targeting, okay, just place it. That placement you will be targeting. Once the placement comfortable, then you will be targeting rotation. Then the rotation is comfortable, then you will be targeting on focus. So you will not be in a hurry. You are not going to cause that discomfort. You will be very sensible if you have gone through that phase while teaching, while learning of your colleagues. Then now next innovation is innovation in the clarity of the mindset regarding technique and learning curve, that it's a invasive procedure. Yes, fine. It's a you keep on the eye, so you are giving a direct touch. Cornea is very sensitive. So, but it's not intraocular. You maintain your hygiene, you learn about it, how to maintain the gonioscope, sterilization to be done. Then the hand stability. Well, gonioscope never start when you have not done 90D. You have to do 90D slit lamp by microscopy, 78D slit lamp by microscopy. That means your hands are stable. Now, once this is done, now you move to gonioscope. So first stage, if you are doing a gonioscopy, when you are not able to see 90D optic nerve and macula, you are not able to move with the blood vessel, then you will be going for the gonioscope. Obviously, your hands will not be stable. And obviously, we discuss about the discomfort to patient has to be minimized. And that's what I said. See, from your mind, please remove that from the very beginning. You have to grade, you have to give the ideal positioning, ideal lighting. See, that is there, but it comes later on. Rather, you focus on placement, rotation, and identification of structure. So, and that much of light should be used so that you can see your hands. Like, the ideal thing is switch off your room light so that it will be in the mid dilate pupil. If the pupil will be mid dilate, the angle will be properly, whether it's narrow angle, because in mid dilated pupil the iris is more closer to cornea. So actually you will be identifying the proper grading of the angle. But that's not how to begin with. You begin with a light position, that much only, to see where is your hand, where is your lens, where is the eyelid of the patient, so that you can place in a proper position. Then that much of light only, so that you can see where you have focused. Are you on cornea? Are you on eyelid? Are you in the mirror? That much of slit lamp light you are supposed to use. And I will not start with a very thin beam so that you can see the wedge of endothelium and epithelium meeting. Please do not start with that mindset learning the gonio. So that comes on later phase, right? So that is what, don't be impatient. Everything has its time, and learn what will happen if you take out a baby before 9 months. It's a prematurity. So rights like that, take your time. So and start from the first year of your residency, so that in final year, you're absolutely confident in and grading the gonioscopy, angles. Okay. So what happens that in your practice, you see there is over reliability of Van Herrick's grading. Van Herrick's can never be compared with gonioscopy. It's just a screening method. Van Herrick's cannot give you the exact amount of angle structure or any of the pathology. Obviously, you have to see the angles. So the mindset and notion that it's it's done by the glaucoma surgeons only. No, it's not like that. It can be very well done by the general ophthalmology from their residency. And as from the very beginning in those statement also, I have written, the beginning of the journey, the mindset decides where you will go. So your mindset should be perfect when you will start, that yes, it can be done, and it is done by residents. So, well, this is a part of the trainers. Few of the students, they reported that we are not encouraged as a part of comprehensive training of residents. So, I am sure, we trainers will also be changing our mindset. We will be upgrading ourselves, so that we'll be imparting this training right in the first year of their residency. But when we are giving training, we have to have this thing with us, because I was recording with her, I was grading key. Okay, she is able to see through the digital. Either you have a side view in the slit lamp, or you have a digital slit lamp, so that you can see what your residents are doing. Otherwise, they will be seeing something. Say, my resident was seeing the rim of the lens, and she's thinking the rim of the lens is the angle structure. It's a ciliary body. She's very happy about it. I saw the ciliary body. So if you don't have, as a trainer, you don't have any accessibility to digital slit lamp, or to side view through of the slit lamp, then you don't know what the residents are doing. So this is something we have to convince to our management to have these things with us. And well, a few students have noted that features like convex iris, cataractous eyes, it is difficult to see the angle structure. That's fine. We also, as a glaucoma surgeon, find it difficult to see the angle if there is a huge convexity. But see, we sometimes, yes, we manipulate the eyeball position, manipulate the lens to see the angle, but grading is always done in primary position. If you are not able to see, but not able to see, the manipulation of the angle and seeing that and then reporting it's open, no, 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 it's not open, right? You have to grade as per the primary position of the eye and the lens. So you're not supposed to manipulate your lens and then grade. Okay. So now let's think that you have placed this already on the eye and you are there. You have got a happy patient to do that. So already if you have done, let's proceed now. So this is the superior, inferior, and temporal nasal angles. So see, inferior angle that you are seeing superior. It is the widest open angle, like the most structures that you can see, and it is the most pigmented. Why it is more pigments? Obviously, due to gravity, the whatever pigments will be coming, it will be settling down inferiorly only. So because it's more pigmented, so you will be able to differentiate the structures better for the inferior angle. So always start with the superior mirror, so that you will be seeing the inferior angle, so that you will be able to identify the structures properly, so that you can make out, okay, whether the patient has really hypopigmentation, more pigmentation. You can report accordingly. Then you go for the other part, like the four mirrors. Okay, so now you have gone to the four mirror. Okay, so now you are so much expert, so now go for this beam. Okay, so see, this is the anterior and posterior part of the cornea, and they are meeting here. That is Solbes line. So this is the Solbes line. So then after these structures, you are already there in the book. You can see every structure, how it seems like, how to differentiate. So because of the time constraint, I'm really not going into that very much, because it's very well available. And in the angle, I want to say, see, normal angle vessels can be visible, but the normal vessels will never cross the scleral spur. So if anything is crossing the scleral spur, that means you are dealing with a neovascularization of the angle. So if you are seeing the angle, blood vessels, please be careful, how much they are crossing in that place. So now, you have seen the structure. So now you are trying with a four mirror. Okay, because that's the ideal one that we have said. Okay, so in the four mirror, this is what you are supposed to see. But if you indent, see the cornea folds. This is the moment you will see this kind of cornea fold. That means you have indented. Indentation means this. See, you have flattened the cornea by giving pressure. The moment you flatten the cornea, you displace the aqueous humor. So the aqueous humor is now pressing the angle. So the angle is open. So where the angle is actually this, but if you indent, you'll be seeing all these things. And that's the mechanism. We do indentation gonioscopy to identify how much, it's actually opening. Here you will be seeing this. See, this is the normal without indentation, and this is the indentation. See the cornea, already these folds are there. So we can make out, okay, this is a positional angle closure, not a synechial angle closure. So obviously a positional angle closure very well will respond to PI done. After PI, make sure to recheck the angles that yes, now it's already open. So now, if you see the angle structures, so there are few things that you should make out. How much is the pigmentation? Because as per the pigmentation, the diagnosis will change, whether it's a pseudoexplanation, whether it's a pigment dispersion syndrome. So all those kind of pigmentation you must note in your examination. How much is the pigmentation you are noting? So this is like, no, I'm talking about the synechy now. See, iris roots are sometimes confused like synechy, but the iris roots will be very fine. They will be like, thread-like structures. But the see the synechy, how much broader, they are, how much irregular they are. So that is how you can differentiate the synechy from the iris roots. Okay, so now because you have seen a little bit, what are the difficulty you go through the gonioscopy, and you should be learning this. Now I must explain you why. Because if I will not say what you will get, what's the transaction you will do from the learning gonioscopy, so I may not be able to explain you the future value of gonioscopy. So where the world is going now, it's all about phaco, right? As a phaco surgeon, you must be dealing with some glaucoma patients in your clinic wherever you work. And now coming to the point of minimal invasive glaucoma surgery, where stents are there in the market, and people want that we need a free from this our anti-glaucoma medication because of the ocular surface irritation effects. We don't want to have so much of medicine, so let's try to have stent. So see, as a phaco surgeon, actually you are the best one, not the glaucoma surgeon. If your phaco hand is best, you are the best person to go for stent implantation. So for stent implantation, what's the gonioscope you are using? You are using a direct gonioscope. So that means you need to be very good in identifying the structures. So while if you have done in your residency, you have used indirect gonioscope in your OPD, you are very well versed with your angle structures. Direct gonio lens, identify structure is not a very big deal now for you. So you can very easily, being a phaco surgeon also, you can go for MIGS stent implantation. And obviously, you know what you will be getting if you are that kind of surgeon. Okay, so what value system it gives you. Now coming to the, next thing that we always, very much sure, the medical legal issue. See, if you put a dilating drop in your clinic and the patient landed up, and because it was a narrow angle, then your optometrist put the dilating drop. Now the patient develop a angle closure attack in your clinic. Now you will be in a medical legal issue for not identifying a narrow angle prior to dilatation. So that's why you should be able to check on gonioscopy where how much is the narrow, can I dilate, or I should go for PI. So that much mindset you need to develop during your residency program only. So now coming to a leading, So because the glaucoma is the most leading cause of irreversible damage, so being a general ophthalmologist or any other specialization you are taking, that you have to go through the glaucoma patient is very commonly found in India. Narrow angle is very common. So, and we can't treat or, you can't decide the progression or predict the progression if you don't understand what type of glaucoma I am dealing with. And the type of glaucoma you cannot identify if you have not done the gonioscopy. So that is how gonioscopy is important. But now also another thing is that foreign body. Foreign body behaves like a foreign body. That means it can come to your practice anytime in your lifetime. So once your foreign body is in the anterior chamber, where it will go? It will go to the inferior angle, because, and if it's very small, you are not able to see in the slit lamp. You will be treating, the uveitis will not be going because in the angle there will be sitting the foreign body. So you have to remove the foreign body. So you have to be good first of all, you have to identify in the gonioscope, and obviously in the surgical gonioscopy you have to remove that foreign body from the angle. So these are the few things that I could explain why gonioscopy you should be learning from the residency only. So coming to my last slide, actually, like how it is being explained that 4-mirror is the best and what kind of light to be used. So this article is really very good, so you can go through, and it really gives the what is the ideal. But please, while starting, do not focus on ideal thing. It is just the starting, it matters. Have you started? So it is better to start than just to think for, okay, what is the ideal thing that I should be doing. So thank you very much for your patience hearing. So I'm stopping my screen share now. Thank you.
Thank you so much, ma'am. That was really a very wonderful insight about the gonioscopy. And I do agree that a lot of times, what you did say that a lot of times the Vanirix gives a very different feeling about the screening. In the screening, we see that the patient is having a grade 4 in Vanirix, and when we do the gonioscopy, it comes out to be a close angle, so it can be misleading also. So with this, I would like to open the podium for panel discussion. Dr. Devintuli sir, your comments about gonioscopy, please.
So, Anindya, first, my congratulations to you. I think you have done a big favor for glaucoma in India by this very nice and lucid presentation. I'm sure following this presentation, many residents and even practitioners will be looking at gonioscopy as you made it easy. So great job, and I would encourage everyone to follow what she said. I would also request Dr. Sood, who's a master of teaching gonioscopy, for his comments.
Thank you, sir.
Dr. Devendra Sood sir. Dr. Sood sir, are you there?
I think we can go to the next.
Yes. Dr. Mona ma'am, your comments about gonioscopy for the residents and general ophthalmology, please.
Yeah, thank you. It was a very interesting to go through a resident's journey of learning gonioscopy. So that was a really nice idea, Dr. Anindya, and I congratulate you for that. So gonioscopy is a part of a comprehensive eye examination and also a comprehensive resident training. So, and I'm sure tomorrow everybody, all of them are going to gonioscope each other, not the patient first, right? So, basically, one thing I would like to add while examining is that it's good to support your hand. So usually for the elbow, you can have an elbow rest on which you can rest the elbow. And secondly, if you want your shoulders to thank you after 7-8 years of gonioscopy, you can use both the hands, like the right hand for the left eye, and the left hand for the right eye. So that will also distribute the load over a period of years. And apart from that, start with the Goldman lens, which is more stable, but you do need a coupling agent for that. And like Dr. Albert was mentioned here, he says that if you need to do an OCT or a field after that, it becomes a little difficult with all the gel on the patient's eye. So ultimately, you would like to graduate them to the next level, because gonioscopy is an art. So you start with the first step and then build up from that. Switch on to a Posner or a Sussman, which can be used for indentation also, and then graduate next to the intraoperative one. So I would just say remove all your mental barriers and start and take small steps to learn gonioscopy. Goldman, another advantage I would like to mention is in case of photography, as well as in case of eyes with CD cleft, you may get a lot of folds. If you use a Posner or Sussman, you can use a Goldman for that also. Otherwise, later on, you need to graduate to the Posner or the Sussman type of lenses.
Absolutely, ma'am. Absolutely. Yeah.
Thank you so much, ma'am. We would move on to Dr. Subhashini ma'am, please, for your comments on gonioscopy.
Yeah, yes, Dr. Anindya, that was a very beautiful, explicitly explained, practical tips on gonioscopy. This is what we need. The other things, as you say, you can learn from the books, the grading, the lenses used. So this is what is more important. I'm sorry, just a minute. Yeah. This is what actually is important. So while doing gonioscopy, it's better to start off with a single mirror. I'm so
Yeah. Swati ma'am, you can chip in, ma'am.
Yeah. Very nice presentation, Anindya. And it is for the first time I'm seeing somebody videographing the resident practicing all the gonioscopes and showing the practical difficulties which the residents actually face. So when I remember when I put the first gonio lens on in my PG time, I had to give party to my seniors that okay, today was the first day I was able to fix the gonio lens onto the eye. And they took me, no, you have to give party. So that's actually what happens when you put the lens on the cornea for the first time, and then you see the angle for the first time. It's really a eureka moment, yes, as a resident. Subhashini
Swati,
ma'am.
that's
Yes,
a
sorry.
brilliant thought. Party wali thought बहुत अच्छी है.
Madam,
Uh,
Subhashini madam, you want to
uh,
continue first?
yeah.
I'll
Sorry
speak.
for the interruption. Correctly, when I'm speaking, the drilling was happening at home. So basically, what for the resident, it's good to start off with a single mirror or two mirror. The stability is there, so you can use viscoelastic rather than lubricant drops. Sometimes, at times, we were using lubricant drops. So a viscoelastic would be good, and then it gives good stability. Air bubbles do not enter, and actually you need to keep the slit parallel to the angle what you're seeing. Supposing you're seeing seeing through the superior mirror, the inferior angle. So you keep the slit horizontally and look at the angle and go quadrant after quadrant. Try not to cross the pupil. So in that way, you will get the
Yeah,
true
ma'am. Very
angle.
practical tip.
Yeah.
Yes,
So
yes,
that is
absolutely.
important. And then when you want to know more details about that particular angle, then maybe you can keep it perpendicular to that angle, and then you can view if there's a foreign body and all that. Those details you can note down. And yeah, so as Dr. Mona Kurana said, for photography, you really want to take good photographs. You need to use a single mirror or two mirror, because otherwise the four mirror tends to slip off. But you were making a point about manipulative gonioscopy. So we actually manipulate means basically we slightly tilt when your view is not there. So when there is over the hill, you want to bypass that iris. So slight tilting of the mirror is required to see the angle structures. So this manipulative gonioscopy is different from indentation gonioscopy. Indentation, you need the four mirror. So you can't do indentation gonioscopy with a single mirror or a two mirror. That residents should be clear about. So these are
Thank
my
you so much. Thank you so much, ma'am. With this, I would like to
Swati
ask
ma'am,
Dr. Prasanna.
Swati ma'am had a comment here.
Yes, yes, ma'am. Please, 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 ma'am.
So we should dim the room lights. So whenever in our practice, automatically when we take the gonial lens, the sister switches off the light, or we also switch off the light, and then we make the beam 1 or 2 millimeter, and we start from the inferior angle, go like this in a circular or a counterclockwise manner, or clockwise manner, whichever you feel you are comfortable. As Mona said, left hand for the left eye, right hand for the right eye, with an elbow rest, and stabilizing the eye, the hand, and the eye. So you cannot just keep on doing like this, because the patient knows the level of confidence that you have, which you are showing onto the eye. So the resident has to start with a one mirror, single mirror or two mirror, graduate to four mirror, as Mona said. And for pictures, yes, two mirror or single mirror is good. And one important thing, start from a lower magnification. And when you are seeing something is a little interesting or something, you increase the magnification. What the residents, what I see in the fellows, they start directly from the higher magnification. So you don't get the full picture and in a full magnification, because your field gets reduced. So start from a lower magnification and then increase to higher magnification. And for all diabetic patients, you have to rule out NVI, NVA, irrespective of whether the patient is presenting with any complaints or not. Because these are very subtle things they need to rule out.
And
That's all.
Swati, remember the party, huh?
Party, yes, sir.
We also have
So
given a
Nandini,
lot of parties.
so
Yes,
Nandini,
sir.
you're missing Tutul, who's our panelist too. So please ask her for comments.
Who, sir? Sorry.
Dr. Tutul is a panelist. She's there. Please ask
Okay,
for
okay,
comments.
okay. Hello, ma'am, are you there, Dr. Putul, ma'am?
No, she's not there. Okay, please carry on.
Devendra sir has come.
Yeah, hello.
Yes, ma'am. Ma'am, your comments about gonioscopy, please.
Actually, it's the most difficult part, and I think the way she Anuradha described is really beautiful. I mean, how from residencies period to how they're graduating. but mostly now I am doing with 3 mirror and always confirming that with 4 mirror. And she's absolutely right that the indentation of the cornea, I mean, the moment you see the folds in cornea, you can know that you are indenting. So, I mean, the whole thing is very tricky. I think Dr. J.C. Das once told that after doing 1,000, then you will be very confident about your gonioscopy. So I think he is right. So it's very difficult, and her presentation is really good.
I just want to add one more point about the 3 mirror. The 3 mirror is a very bulky lens. It's mainly for seeing the pars plana area of the fundus, the periphery of the fundus. That should not be used for gonioscopy, though there's a mirror to view the angle. So it's very cumbersome, and it will only reduce the confidence of the residents. So it's better a single mirror or a 2 mirror would be the ideal thing.
Actually, for I think in WGC, if you see, they are showing the whole gonioscopy with 3 mirror. I think Prasanna can remember. That is, they use 3 mirror for the teaching. So after that, I found 3 mirrors teaching is not that bad. So I think you are every day you are dealing with teaching, so you maybe better know that how the graduation should be start from single mirror to double mirror, 3 mirror or 4 mirror. So that is different issue. But for personal use, I always use 3 mirror and then 4 mirror because at WGC, I mean, they have shown that the way is doing gonioscopy. And one more thing, if you just please differentiate between one is that you just ask the patient to look up or down to see the mirror, that is I mean to see the angle. And other thing is that you just occasionally, I mean, your light is less and you can see slit is less, you can see the angles. So these are not definitely I mean, which will be the proper way? I mean, see the angle. I mean, always in the dim light, everything is fine. But when we see in the proper angle, sometimes we ask the patient to see the upwards or downwards. So I think this should be avoided, right?
This manipulative gonioscopy is like that when you're not able to see the angle structures. So you ask the person to look towards the mirror, and then you can see the angle structures.
So just like to add that basically we should know what the purpose is for the gonioscopy which we are doing. First is to identify whether the angle is open or closed. If it is closed, is it occludable or is it there are sine K. So once that, or is it completely open? So once that part is taken care of, after that you can increase the light, increase the magnification, basically to look at the details of the angle and look for, like for example, pigmentation, NVI angle, NVA angle session and other things. So we should be very clear in this format that why we are doing this step of gonioscopy. So for each step, the instructions to the patient and what you are looking for are totally different, basically. That's what I feel.
So what is the exactly definition of manipulative? I mean, when we increase the light, this is also manipulation. When we increase the patient to ask upwards, downwards like that, that is also manipulation. So, I mean, the moment you are increasing your light, the moment you are asking your patient to look up, down, right, left, this is manipulation. So exactly to identify occludable, non-occludable, just dim light and you see at the present static position what you see, you just draw. This is the gonioscopy, right?
Absolutely. That's the thing.
Absolutely. Yeah.
The primary position.
Is a primary position.
That's
So
the primary position.
yeah. So whatever you do after that, that will be manipulating, even in the light or anything. I mean, and
Absolutely.
when you just tilt your gonioscope, that is also manipulative.
Yes, absolutely.
Okay. No, I think Dr. Sati said that something about manipulative, the tilting about position. So that also should be included in the manipulative.
Absolutely. Yeah. Tilting
Absolutely. Yeah.
Yeah, ma'am. We take decisions only what we are seeing in the primary gaze, without any movement of the eye
Or the lens.
or the lens.
And also about the light. It should be the dim light only.
Dim not crossing the pupillary margin.
Dim not crossing the pupil.
Dark room.
Dark room.
Thank you. Thank you, ma'am. Ma'am, if I may add a point from a mixed surgeon point of view. We start with a single mirror or a two mirror gonio lens with a coupling fluid of viscous agent. And then what I felt for direct gonioscopy transition is if you are able to then move towards a Zeiss lens, a Sussman or a Posner without getting your striations in the cornea. That's the exact amount of pressure that you need to master, especially with your non-dominant hand for moving towards your mixed surgery. So as we are in the era of MAGS today, I am calling for my residents and fellows to do gonioscopy with both hands. So if you are examining the left eye of the patient that is exactly opposite to you, I tell them to use your right hand to give the axial pressure and then move the joystick with your left hand. And if it's a right eye of the patient, use your left hand and then move it with your so the ambidextrity, especially bringing the left hand into picture, because most of the fellows and residents have the tendency to use the right hand because they are right hand dominant, and that is one difference we have noted when we move to MIGS. They get a lot of striations because of the axial pressure. So
Absolutely. Yeah,
my
it's a
take
very, practical tip for the residents that they should be starting from now.
my
Yeah.
take is start with the lens with a flange, a single mirror or a double mirror, as Subhashini ma'am was saying, and a three mirror, as also Tutul ma'am was saying. Then move to a non lens which has the tear film as the coupling fluid, and then go to your direct gonioscopy. Yeah. So thank you, all seniors for a very valuable discussion. I think shall we move to the next set with that? If there are no further
Sure.
discussion. Yeah, thank you. Thank you, ma'am. Thank you, sirs. So with that, we'll move to the third lot for the day. So we had a very good set of discussion on tonometry. Then we had on gonioscopy. So with that, we are now moving to the visual fields part, that is the scotomas. So first, we are going to have from blind spot to field effects from Dr. Pooja, ma'am. Over to you, ma'am, for your talk on scotomas.
So thank you so much, Dr. Prasanna, and also AIOS and the GuruSangam team for inviting me over. At the outset, I want this is a disclaimer that sorry, I'm the wrong one. Let's see.
Ma'am, I think you are in your guest account, ma'am. You might have to.
Now
log
is it okay?
Yeah, perfect, ma'am. Yeah.
Yeah. So, um, yeah, the disclaimer is that this is not a purely glaucoma topic, and it overlaps a lot. It overlaps even neurology and neuro-ophthalmology, retina, and glaucoma, of course. But and of course, if I may say so with a pun, that the teaching of scotomas, and especially in PG students, they don't know much about what it means and what types there are, and it has been a blind spot as far as the PG education is concerned. So let me start my presentation. Yeah, so if this is what you see, you are looking through a scotoma. So from blind spots to field effects scotoma. So what exactly is a scotoma? So colloquially, it is an island of darkness in a sea of vision. Well, darkness itself comes from the Greek word skotos, and scotoma itself is from the Greek word scotoma, which is giddiness. It could be derived from the blackouts that we have during an episode of giddiness or fainting. So, technically, it is a reduced or absent sensitivity in the visual field surrounded by normal vision. So we know that the visual fields that we have, let us first get introduced to that, is like superiorly and nasally, we have roughly 60 degrees of the visual field. Inferiorly, Again, there's less obstruction of nasally. There's an obstruction due to the nose, superiorly due to the forehead and the frontal bone. Inferiorly is just the cheek, but it's less. So it's 70 degrees or so. And temporally, there's hardly any obstruction. So we have around 100 degrees of visual field. When we are seeing binocularly, binocular visual field overlaps and the visual field is much larger. And of course, we do utilize our faculty of fusion when we are using both eyes. And so let us now come to the types of scotoma. So based on visibility through the scotoma, we divide it into relative and absolute based on the recognition of the patient. It's either positive or negative. And based on the etiology, it's either physiological or pathological. Let's see each type. So what is a relative and an absolute scotoma? Well, the one on the top, very obviously, is a relative scotoma. You can still see through it. You can see some details, or albeit they can be distorted or minimized, or they can either be smaller or larger or distorted. Yes, but you can see through them. And the one on the lower panel is the absolute scotoma, through which you cannot see anything. So what about this? So this is a zone of relative, and in the center is an absolute scotoma. Usually in pathologies, this is what happens, right? Because the center part of the pathology may be an absolute, and the developing part or the increasing part or the progressive part may be a relative scotoma. So this lecture is predominantly about a patho-anatomical or pathophysiological basis to and the basic science behind what we usually see. So what do you think will happen in a CSER or central serous retinopathy? So yeah, it would be a relative scotoma. What about a retinoschisis? Well, it in a retinoschisis versus a retinal detachment, because of the area which is detached, the retinoschisis is intraretinal, so there will be a disruption of the layers and the connectivity, the neurological connections, and so it will be an absolute scotoma. Whereas in a detachment, it may progress initially from a relative to later absolute once it becomes more chronic. So this is in one slide, both of them. The one in the center is a detachment, whereas on the sides is a retinoschisis on an OCT image. So what about this? What do you feel? This is a lens drop, and the lens is a relatively clear lens, and it has fallen on the retina. So do you think this will be an absolute scotoma? No, there's light still going through it, right? So even though it's distorted, the patient might see something through it, but yes, it is a relative scotoma. What about this? This is some opaque lens matter, possibly a nucleus, a part of the nucleus has dropped, and the part which is more dense would have a absolute scotoma, and the parts at the periphery, the cortical fluffy matter, could be relative scotoma. So now, based on how the patient recognizes it, positive versus negative, well, let us think of this image which is formed in the retina, this image of a cross. Now, there are two ways in which it may not be seen, right? The first is if there's something blocking it. Either it can be a relative scotoma, an absolute scotoma, or partial, right? Partially blocked. So this is one of the ways in which this image can be blocked. But another way in which we may not see this image is if there's a gap in the image. So when I teach the residents this point, I usually have a paper where I draw a diagram, and I just either uh, cross it over, or then I just stare it. Even in this technique, even in this instance, you will not be able to see the cross, right? So this is a negative scotoma, where the rods and cones, or the mechanism, or the sensory structures that we have are damaged, and therein the patient does not see anything in front of the eye blocking the vision. the patient most likely in a positive scotoma will say, oh, there's something in front of my eye. Whereas in a negative scotoma, where the actual cells are absent, destroyed, or pathologically affected, in that case, the patient will not note anything. There's a gap in his vision, there's a hole in his vision, and that is because there is no sensory apparatus over there. So, this is similar. This picture on the left is a negative scotoma of the center of the pencil, whereas something, a blob or something obstructing the vision, is a positive scotoma, which is seen on the right. So let's make it a little fun. Yes, he who sees not and knows that he sees not is possibly seeing a positive scotoma, wherein a person who sees not and knows not that he sees not is positively experiencing a negative scotoma. And we all know that this, look at this now. Now, this is a vitreous hemorrhage, the preretinal hemorrhages. What do you think this will be? The retina, the actual photoreceptors would be normal, right? So, this is something wherein you will have a positive scotoma. What about the disc itself? This is the most famous or the most common cause of a negative scotoma, wherein there are no photoreceptors in the area of the optic disc, and hence the patient, it's a hole in the patient's vision. The patient doesn't know it exists because nothing is obstructing it. It's just an absence of vision, or there's an absence of visibility in that area. So what about an age-related macular degeneration? So here again, the cells are involved. There's a dying of the cells, there's scarring. So again, there will be a negative scotoma. And what about this? Here in this case, there can be a negative scotoma. There's a scar, the cells have died, and the photoreceptors have been damaged. But in the peripheral part, some of them may have survived, right? So even in this setting, in a negative scotoma also, you may have a central absolute scotoma and a peripheral relative scotoma. So this is, I didn't find anywhere online also, but I just want to bring you back to your optics and physics, which you all studied possibly before entering medicine and the field of medicine. And yes, you remember when we had the source of light and there was an obstruction in the middle, there it could either cause the main or a more dense shadow, and there can be a peripheral not so dense or a partial shadow. So I just laid out into the open that possibly if there is a opacity in the vitreous or a hemorrhage in the vitreous, and that itself can lead to both this penumbra and umbra, and we never know. It could just behave in this way, right? So this is that instead of this red circle here, it could be just a vitreous hemorrhage, and it could lead to a scotoma. So now let's come to based on etiology. So the scotoma could be physiological, as we've already mentioned. The optic disc is the most commonly mentioned. We all have a negative scotoma. We all have a physiological scotoma in the form of the blind spot, which is corresponding to the optic disc. And in a case which is pathological, for example, papilledema, this space occupied by the disc is increased, mechanically increased due to the intracranial pressure, the back pressure due to that. So effectively, the space occupied by this disc or the part which does not have photoreceptors has increased. So in that case, what will happen? The blind spot will become enlarged. And that's exactly what we see, the enlargement of the blind spot. So again, the classification can also be based on whether the scotomas were temporary or permanent. And let us see, I think you can guess now that those that can be treated or those that come in very transitorily, these are the ones which will be temporary. So, for example, subretinal fluid, CSCR, these can be treated, and they may be temporary. Once they're treated, they may go away. Edema, macular edema, hemorrhages, they can resolve. And of course, let's not forget this special type of scotoma called the scintillating scotoma of migraine, which is the migraine with aura. We're going to look at this a little later. So again, based on pathology, the scotomas usually belong to the retina in the eye, either the retina, the optic nerve, or even in front of the retina, right? The vitreous, etc. So, and the non-ocular ones are usually the CNS or the nervous system, and they can be vascular like migraine and other vascular causes. Of course, on the retina also there can be vascular causes like the retinopathies, the AIONs, etc., as well as venous occlusions, etc. So let's go on to the special. So, okay, so this is how they look. So if the scotomas are more on the retina, then you can have a central scotoma. We are coming to all of these. The arcuate scotoma, you could have an altitudinal defect like an AION, centrocecal scotoma, generalized constriction, and of course, in once you go beyond the eye, you can have at the level of the optic chiasma, which is a heteronemus, and then once it crosses the chiasma, it becomes homonymous, and you can have the hemianopias, the quadrantanopias, and you can have the cortical involvement. So what exactly is a blind spot? Well, this can be a Viva question, an MCQ question, you name it. Yes. So based on visibility, these are all our classifications put together. So based on this, a blind spot is an absolute scotoma. There is no photoreceptor. It is a negative scotoma. The patient doesn't know about it. It's a physiological scotoma. It is a permanent scotoma. It's not going to disappear anytime soon. And it's, of course, related to the optic nerve. So the blind spot, again, it's physiological. We know what causes the enlargement of the blind spot. Where is it located? So in a field, it's going to be located around 15 degrees temporal to the fixation in a field and slightly inferior, because this corresponds to the relationship between the macula and the optic nerve head or the optic disc. So how do you check? Well, if you see this diagram and you look at the circle which is to your left, you are supposed to look with the right eye and then slowly either move the screen forward or backward till you cannot see the cross. And that's the blind spot for your right eye. Similarly, you look with the left eye and look at the cross and move the screen forward or backward until you cannot see the circle. Similarly, you can do it with a two-thumb test. You can keep one thumb, the left thumb for the right eye, and then move the right thumb away until you can't see it, and vice versa for the left eye. So you have the thumb test, you have this circle and plus test. You have, of course, the Jerem screen, and of course, the latest and what we all do is the field analysis, and that is the best way to check for the blind spot. So this again can be an MCQ question, it can be a Viva question. What are the methods of finding the blind spot? And what happens in a blind spot is that that part of the vision is missing. The patient doesn't even know about it, and yet there is an area which is missing from the visual field. But when the fields of both eyes come together, as in a binocular visual field, one eye compensates for the other because of the mechanism of fusion. And hence, we don't actually miss any point in our visual field as far as the overlapping binocular fields are concerned. So let's come to papilledema. This we've already covered. It's just the enlargement of the blind spot, and that is the scotoma. And for optic neuritis, yes. So for optic neuritis, you can have these various types of scotomas, right from quadrant to multiple quadrants to altitudinal, either superior or inferior. They could be central, they could be centrocecal, and or they can be diffuse dimming or a diffuse depression of the visual field. So these are the types you can find. And of course, in multiple sclerosis, you may also find arcuate and blind spot enlargements, which you may also see in other forms of optic neuritis. So what about AION, which is anterior ischemic optic neuritis? As the name suggests, it's ischemic, so it is blood vessel or blood supply related. And we know that there are two types: is the arthritic type and the non-arthritic type. So what type of field defects will you have? Yes, again, here you'll again have altitudinal defects. Inferior nasal defects are common. Of course, centrocecal defects may be found. And we know that the causes may be hypertension, atherosclerosis, and even hypotension of the blood supply of the optic nerve. And then the arthritic type, which is usually due to a vasculitis, maybe giant cell arthritis, and this is caused by inflammation. So this is the type of altitudinal defect. These are types of cecal, central and centrocecal to the left. These are types of defects that we can see. Of course, I'm sitting in a glaucoma session, and Chakrabarti madam will be covering most of this, but it would just for the sake of completion, I would like to stress that, of course, there is this horizontal raphe, and this is the way the nerve fibers enter the optic nerve. So the nasal fibers are more or less direct. Even the spindle-shaped fibers coming from the macula, they come in almost directly. However, from the rest of the retina, the periphery, they curve around them and come to the disc either superiorly or inferiorly. So the superotemporal, inferotemporal, and they are the ones that are more crowded, and inferior being more susceptible to superior. And so this is how uh, the defects can start uh, along these fibers first. So that's how, if you superimpose a field on a retina image, this is how it is. PGs often get confused as to what should be the center. The center is always the macula. The center is always the fovea, and the disc is temporal in the visual field to the fovea, because in real life it is nasal to the fovea. And there, depending on the distribution of fibers along the with respecting the horizontal raphe, as I showed earlier, the fibers, the ganglion cells and axons will be lost, and that is what it causes the field defects in glaucoma. So the spectrum can be from a relative to absolute. And of course, testing is by way of perimetry, which classically used to be the kinetic type, and now we are resorting more to the static perimetry. The newer types and the ones that detect only a certain types of ganglion cells is the SWAP, or the short wavelength automated perimetry. And there is a role of the coniocellular pathway, which is just 5% of the ganglion cells, and the remaining 80% is the which sees the acuity and the color vision. That's the parvocellular, and the magnocellular pathway is the one which is the remaining 15%, and it tells us about the temporal movement of the images that we see. So this tests the 5% coniocellular ganglion cells, and they are have in order to test the blue. So these are the blue cells. So in order to test these, the remaining background should be made yellow, because then it suppresses the red and the green cones, and then the blue cones can be detected, and then that's how it is used. Of course, these respect the horizontal raphe, and it is said that yes, some of them in hypertension, one field may be involved more than the other in glaucoma. So if we superimpose what we see on perimetry, this is how it looks. So this is how our usual perimetric field looks, and this is corresponding to the field. The disc is slightly above and nasal to the macula, and so on the field it is slightly below, around 15 degrees temporal, and inferior to the macula. So again, in a glaucomatous field defect, you may have a relative component and a absolute component in the same field defects. And of course, we know the various types. I'm sure the next speaker would be covering more of this. We have the nasal step. Based on these distribution, the sedal scotoma just below that, then the temporal wedge. Of course, when it starts with paracentral and then they join up, and the sedal scotoma and the arcuate scotoma, also called the Jerem scotoma. Sometimes you may have a double arcuate, and then you may have a sparing in the center, which is a macular sparing, and the double. So it's like a ring, or a yeah. So that will how the glaucoma defects behave. So just a word about the blue on yellow perimetry. It detects more early changes than the routine white on white. If the white on white shows a certain size, the blue on yellow shows somewhat larger defects. There, even ocular hypertensives may show a positive scotoma on blue on yellow. There is a prognostic or a predictive component in these blue and yellow ones. They may even precede the white on white ones by 3 to 5 years. And another theory is that possibly blue and yellow may also work because the ganglion, the cell fibers or the are more superficial. So and blue is a shorter wavelength. So that's another reason it might work. Uh, yeah, so most of these patients do have a risk of uh, getting proper field effects on white and white, but these take longer to perform. The lens, of course, we know has a propensity to absorb ultraviolet light and all the shorter wavelengths. So yes, it could be difficult and challenging. And of course, there's more short-term variation when we do these tests. What about migraine? So yeah, we know classically that the classical migraine, not the common one, not the common migraine, the classical migraine has the scintillating scotomas, which are zigzag shaped. And classically, these are also called as, yes, you guessed it, the auras, right? So this is a migraine with aura. So, of course, a special type of scotomas, let's see them. We've just seen the scintillating type, which is mostly due to migraine, but it could be due to other reasons like hormonal, certain types of coagulation disorders, even retinitis pigmentosa, it is said or reported, and cancer-associated retinopathy. The junctional scotoma, yes, that's another special type, again in neurology. This happens due to the von Willebrand knee, which is at the level of the chiasma. The fibers from the opposite inferonasal fibers from the opposite eye cross over in the form of a small knee into the chiasma of the towards the right side. So if it's a right involvement, like as seen here, we'll have a central scotoma in the right eye and a superotemporal corresponding to the inferonasal fibers. So, of course, these are the other causes: pituitary tumors, craniopharyngiomas, aneurysms, infective and demyelinating causes. Of course, the ring scotoma is classically called due to bullseye maculopathies, including chloroquine, other bullseye congenital conditions, Stargardt's, rod cone dystrophies. But yes, the two, even in glaucoma, you can have a central sparing and a, yeah. And then, of course, the macular degeneration with a sparing of the central part. Hello. And then functional scotomas. Functional scotomas can happen in a panic attack, where the patient cannot see anything on the periphery and can only see what is happening in the center. This is psychologically induced. Of course, there can be even spiral scotomas, as you can see in the lower right. Retinal lesions. What exactly happens in any retinal pathology? If we just break it down, it's going to be either edema or cell damage, or there's a bleed, or there's a scar, right? So what are these conditions which can lead to scotomas? So it can be age-related macular degeneration, it could be vascular conditions, it could be the actual retinopathies like diabetic, hypertensive, it could be macular causes, and of course, we've already seen retinal detachment, retinoschisis. But what happens if I can just ask you, is there any way in which you can know what type of these pathologies is possibly behind the scotomas? Can you know that in the central absolute zone and in the intermediate zone, something's happening, right? With these scotomas, you may either have a micropsia, a macropsia, or a metamorphopsia, simply a blurring. So how does that happen? So just imagine this balloon. Again, this is usually I take a balloon or a glove, usually when I'm teaching this, and imagine that with a given source of light or the stimulus, it is activating 4 dots. So equivalent to, let's say, 4 cones are being activated by a given uh, image. So when this balloon enlarges, that means when there is similar to retinal edema. Now what's happening? Now it's stimulating just 1 or 2 dots. That means it's stimulating just 1 or 2 cones. So the brain thinks, oh, if it's stimulating just 1 cone, it must be a very small image. So what happens? The brain perceives it as micropsia. So when there's edema, the brain perceives it as micropsia. Let's see what happens when the same circle, same diameter of stimulation, and when there's a contraction due to a scar or due to, yeah, so this is what happens. So what was initially stimulating 4 dots of 4 cones is now stimulating 8 or 9 or 7 cones. So the brain perceives it as, oh, if it's stimulating 7 or 8 cones, it must be a larger object. So if in fact this shrinkage or the scarring actually causes macropsia. So what about this? Again, the same instance, and this is when the shape gets distorted, and this is what happens when different, not the same cones are now stimulated. It may still be 4 cones, but not the same ones. They are the ones on top or bottom. So the shape perceived by the brain is different, and that's what is called metamorphopsia. Again, another way of looking at these field changes is if these get blurred and slowly disappear. So from relative to absolute, this is how they can disappear completely when the blood vessel, when the photoreceptors are dying. So this is the relative and absolute scotoma. So again, CNS lesion, again, this is just for completion. We cannot cover everything, but definitely up till the area of the chiasma, there will be heteronemus, and beyond that, there could be homonymous defects. There can be a pie in the sky with a Mayer's loop, where the optic radiations go through the temporal, the inferior radiations go through the temporal lobe, and the superior go through the parietal lobe. So it could be a pie on the floor. And of course, we know that the occipital lobe, the central macular fibers reaching the occipital lobe, have a dual representation on both sides, as well as they have a dual blood supply also, both middle and posterior cerebral arteries. And so there is a sparing in a cortical blindness. Again, this is the same thing. Uh, how do we examine a scotoma? Yes, of course, we need to see the visual acuity. We need to see the pupil for the anterior chamber depth, the anterior chamber, the iris. Yes, to get an idea about what is the pathology. We need to do a red desaturation test, as we usually do for optic neuritis. And we need to do a good fundus imaging. We have most of the causes out there. And a visual field, of course, that's non-negotiable. Of course, we must not miss an Amsler for the first for the central 10 degrees. So OCT is a must if you have the facility and it can corroborate your findings, especially if you have a retinal cause. So so what can happen to a scotoma. A scotoma may progress, it may become from relative to absolute. The patient may have difficulty in concentrating because he can't see parts of the field, right? And then there's difficulty in orientation because he may not see one step, he may not see one part of something that he's looking at. And then again, the patient may have social or issues related to psychological issues. So the management can be, of course, the actual scotoma may be managed by magnifiers, because again, you're just stimulating more cones and you may bypass the ones that are destroyed. And prisms, you may just shift the image off from the cones that are not working to the ones that are more healthier. And the pupillary dilatation works in the same way, and of course low vision aids. So now, of course, we this is my last segment, and we when we study ophthalmology, when we study the eye, we study the science behind it, right? We study the lessons, and I usually don't ever let my PGs go without a little life lesson also that that the eye usually teaches us. And life lessons from a scotoma, well, it could be blind spots in the system, right? We can have a blind spot in the legislation, we can have a blind spot in nature, we can have blind spots in leadership and business, we can have blind spots in marketing, in generational changes, we can have blind spots in technology, and of course, blind spots in health. So, let us now just a fun example that are we personally also, do we personally have a blind spot? Yes, we have the optic nerve as a blind spot, but are we really looking at things the way they should be, the true nature of the things? Are we really looking at the true nature of what is to be seen? Well, just imagine that this is a healthy, happy child, and this child is not perceived in his true form by, this is how he should be seen, right? This is how the child should be seen. But by the teacher, she doesn't perceive him in his right form. She has her judgments, so they create this scotoma. She doesn't see him for what he is. And this is what is the block scotoma. Then the mother of the child, she sees him in a different light. She sees him through the blurry eyes of a mother. She doesn't want to appreciate all his pros and cons. She also doesn't see him in the truth of what he is. And this is what is the blurred scotoma. And then the father, of course, has a distorted view of the child. He thinks he's more powerful than he actually is. And that, of course, is the distorted scotoma. And the girl in his school, the crush of all other batchmates, possibly doesn't even know that he exists. And that is a missing scotoma. So how many scotomas are we using in our lives? Are we missing out things that hide the truth from us? Are we blocking out things that hide the truth from us? Thank you so much.
Thank you, Pooja ma'am, for a extensive and a wonderful talk on scotomas. Devin Tuli sir, okay, Devendra Sood sir, your comments. Okay, Mona ma'am, your comments, ma'am.
Yeah, thank you, Dr. Pooja, for shedding so much light on scotomas that you made them totally disappear. So, for glaucoma point of view, we mainly deal with your negative scotomas, and why they are basically not perceived by the patient is because of mainly the cortical filling in. The brain tries to fill in for this negative scotoma, so they are not perceived. So all the scotomas which you showed, it's important for a glaucoma person to know these, because many times patients come as suspects or with a borderline IOP and a field which has one of these field effects. In that case, you really need to look at the complete picture and correlate clinically whether it's actually due to glaucoma, or investigate into the other causes which you have shown, rule out these causes. Sometimes it may be just a scar in the retina, an old healed scar, which you may be thinking is a glaucomatous field defect. So in that case, three things can happen. One, it can be non-glaucomatous, or sometimes two diseases can coexist, or a person with glaucoma which is stable then suddenly progresses to develop a sudden field defect, which may actually be maybe part of a hemanopia or a quadrantanopia. In that case, it should be a red flag, and unless it doesn't fit in the clinical picture, we should investigate for almost all the causes which you showed us, and correlate clinically, look at the disc, the rim pallor, and all the red flags which we have learned. That's my take-home point.
Thank you, ma'am. Thank you.
Thank you, ma'am. Subhashini, ma'am, your comments, ma'am.
Yeah, ma'am, Dr. Pooja, ma'am, that was a very complete presentation on scotomas. I just would like to ask one question. So, in glaucoma, we know that 24-2 is the standard fields that we order. When it comes to neurophthal, so which would be the fields? The central 30 dash, or the earlier thinking was always the full field
Yeah,
or the peripheral
full field,
fields.
full
So,
field, yeah. So
so
of
which would
course,
you recommend?
the neurological fields respect the vertical meridian as opposed to the glaucoma, which respects the horizontal. And we usually go ahead with the 30-2 right now. But earlier, of course, we used to have neuro fields, and we used to have those crosses in the 60 degrees field, and that's how we used to do it earlier. Um,
Yes, now the present recommendation is central 30-2 fields
yes,
itself would
yes,
be
more,
informative even for neurophthal
yes.
defects when you are suspecting. What I would like to add is like glaucoma produces very characteristic field effects. So as but then still there are other conditions that can mimic glaucomatous field effects, especially the arcuate scotomas and the central and the centrocecal. So there the question comes, as Dr. Mona said, there can be coexisting problems also along with the glaucoma. So there we should not look at just the field effects and think it's because of glaucoma. The worsening could be because of coexisting conditions. So that's my few tips for the residents.
Thank you. Thank you, ma'am.
Thank you.
Swati, ma'am, your comments, ma'am.
So, Dr. Pooja, very nice presentation. Like, it was so good for all the residents who are attending. It was like one full answer. So, from my side, whenever we see a field, how do you say whether it is the nasal or temporal? So, what I always say, wherever there is the blind spot, it is that eye. So, if the blind spot is on the right side, that is the right eye fields. If the blind spot is on the left side, that is the left eye fields. And the blind spot is on the temporal side because it is opposite. So, if everything is hidden out, and if you're just given a total deviation or a pattern deviation plot, you should see the blind spot. Then you should see the nasal, temporal. So mentally you can mark out, and then you should start reading the fields. So the PG should know, at least they should be fluent in reading out 24-2 fields or 30-2 fields. And yes, neurological fields, very, very important. And also the artifacts which are like mimicking fields, but they are not the real true scotomas, like the upper lid defect causing a superior scotoma, like because of ptosis and all. They should not immediately say it isn't superior arcuate scotoma, but actually the patient was not having any glaucoma, it was the ptosis. So these are small things that they have to be aware, but just to identify the eye just by the fields, just by the printout, they should know. And then to mentally get a picture of what is happening in the patient's eye, then they should relate it clinically, whether it's an inferior NFL defect or an inferior notch and a superior scotoma, and then correlate with OCT. So thank you so much.
Thank you, ma'am.
Prasanna, you are on mute.
Yeah, thank you. Thank you to all the panelists. Handing it back to Sunandini to introduce the last speaker of the day.
Thank you so much, Dr. Prasanna. So with this, I would like to invite Dr. Hatul Chakravarti ma'am for her Hatul Chakravarti ma'am for her talk on glaucomatous visual field effects, the different types. Ma'am, handing over the mic to you.
Fine, thank you. I'm just going to share it.
Yes, ma'am. You can share your
Is
screen.
it? Yeah. So it's not, I'm audible, I believe.
Yes,
You
ma'am.
are audible, ma'am.
So
Continue.
So may I start now?
Yes, ma'am, please.
So today's topic, types of glaucomatous visual field defects. Now, first I would like to start with definition of glaucoma. Currently no widely accepted gold standard definition of glaucoma. The definition of glaucoma in adults has changed over the years due to changes, number one, in our understanding of how glaucoma affects the eye, the technology available, and number three, the reasons why a particular definition was constructed. As per consensus, progressive structural optic nerve damage is the best gold standard for glaucoma at this time. This diagnosis is based on Glaucoma Diagnosis, Structure and Function Consensus Series 1. Now here we can see the progressive optic disc excavation with uncontrolled primary open-angle glaucoma over a 3-year period. You can see very well that is the inferotemporal region, that is where arrow is there, is a thinning and also disc hemorrhage. Now the question is why perimetry is needed. Perimetry serves two major purposes in the management of glaucoma. Number one, the identification and quantification of abnormalities in the visual field. And number two, longitudinal assessment to detect glaucomatous progression and measure rates of changes. Now there is another view. Diagnosing glaucoma without staging may be an incomplete process. To properly stage the disease, like disease stage, whether severe or early disease or the moderate, a perimetry test is necessary. So there are two primary uses for SAP. The first is diagnostic step, as it helps document the normal range of vision, and the second use is for monitoring the eyes for any progression of the disease. Now, SDOCT can show the progression. So here we can see SDOCT images showing progression RNFL loss. We can see the progressive loss of RNFL in the inferotemporal sector from 2018 to 2013, and the loss is quite, we can document it. But there is some disadvantage of OCT compared to visual field. Assessing glaucoma progression, OCT has several disadvantages compared to visual field. Number one, the treatment goal in glaucoma is in the visual function domain. Number two, the relationship between visual field status and quality of life is well established. There is nothing similar for relationship between quality of life and any structural parameters. Flow effect in OCT makes it impossible to find any further detection in eyes with moderate to severe visual field loss. So OCT progression cannot replace the visual field progression according to EGS 5th edition. Now, the hallmark defect of glaucoma is the nerve fiber bundle defect that results from damage at the optic nerve head. The pattern of nerve fiber in the retinal area sought by the damaged nerve fiber bundle will correspond to the specific damage. Retinal nerve fiber enter the optic disc in a specific manner. So you can see here the specific manner, and to understand any specific glaucomatous defect, we should learn the course of arcuate bundles, papillomacular bundle, and horizontal raphe. First, I would like to start with the location of initial glaucomatous visual field defect. There may be two types, parafoveal scotoma, paranasal scotoma, parafoveal scotoma within points 0 to 10 degree, paranasal scotoma points beyond 20 degree. Initial glaucomatous visual field defects are localized. On disease progression, these focal changes become broader, deeper, and most abundant. The rate and mode of worsening of visual field defects may vary significantly between the patients. Let's come to the characteristics of parafoveal scotoma and paranasal scotoma. Here you can see is the parafoveal scotoma and other one is the paranasal scotoma. Location-wise, initial parafoveal scotoma occurs in the superior chemifield in both normal tension glaucoma and high tension glaucoma. Regarding disease severity, initial parafoveal scotoma is deeper and localized. Initial parafoveal scotoma presents with a higher mean pattern standard deviation than paranasal scotoma in both normal tension glaucoma and high tension glaucoma. Disc hemorrhage is also more and is associated with initial parafoveal scotoma. Now, systemic factors like systemic hypotension, migraine, Raynaud phenomenon, and sleep apnea all are associated with initial parafoveal scotoma. IOP independent factor, risk factor rather associated with initial parafoveal scotoma. Next comes the test retest failability. Point-wise failability is the lowest in the initial parafoveal scotoma, and because the damaged test locations, they're centrally located. So point-wise failability is the least. Point-wise failability is common at more peripheral points. Visual field defects of normal tension glaucoma differs from that of high tension glaucoma. Already we have mentioned that visual field defects that is morely in normal tension glaucoma, IPS type, deeper and localized, whereas visual field defects in high tension glaucoma significantly more diffused. And already we have mentioned that initial parafoveal scotoma occurs more often in the superior hemifield than paranasal scotoma in both normal tension glaucoma and high tension glaucoma. Here you also can see this, and normally it is not the superior only, it is superior nasal hemifield. Now, optic test ream in normal tension glaucoma and high tension glaucoma. In normal tension glaucoma, the optic test ream is significantly thinner than in high tension glaucoma. The largest difference occurs in the inferior and inferotemporal region, as you see here in this, thinning of the RNFL and the rim thinning. Detecting early glaucomatous visual field damage. The gold standard for detecting early glaucomatous visual field damage is Anderson-Patellar criteria on HFA 30-2 or 24-2 program. There are three criteria in a location typical for glaucoma or glaucomatous damage: a cluster of three non-edge points depressed at P less than 5% and one of which P less than 1% in the pattern deviation probability plot in a single chemifield, either superior or inferior. Second criterion, GHT results outside of normal limits, and third one, abnormal pattern standard deviation with P less than 5%. Please note that meeting any one of these three criteria is sufficient for diagnosis and confirmation by consistent findings on two consecutive fields. So this is a early glaucomatous changes. Now, GHT classification is very important to understand the abnormal visual field in glaucoma. Glaucoma chemifield test classification, there are 6 types: outside normal limits, borderline, general depression, abnormal high sensitivity, within normal limits, and the dual statement of borderline plus general reduction of sensitivity. The GST interpretation outside normal limit is the single most efficient method of visual field interpretation. It is claimed to be the most accurate among all these three criteria for detecting early glaucomatous visual field defect. Now, early glaucomatous visual field defects often come and go. It happens for years before finally becoming clear and repeatable. You can see here in 2017, June 16, there are abnormal points in the inferior nasal chemifield. 2017, the abnormal points are there, but they're fluctuating. Same is in 2018, May 24, the abnormal points are more abundant. So ultimately, December 12, 2019, you can see in the total deviation plot and pattern deviation plot, both, the plots, we can find the abnormal defects and you can see them also in the grayscale. Early defects can be seen in probability maps before it is evident in the grayscale. So if you don't find them in the grayscale, please look for abnormalities in the probability map. Just I am placing one examples of worsening of initial parafoveal scotoma and paranasal scotoma over the years. Now these patients, inferior retinal nerve fiber thinning, you can see the arrow. In 2014, you can see clearly paranasal scotoma, inferior parafoveal scotoma and paranasal scotoma. Now, gradually, the defects are increasing. Ultimately, you can see in 2019, definitely the arcuate scotoma is the deep arcuate scotoma. So, worsening of the inferior parafoveal scotoma and paranasal scotoma over the years happens, and you cannot predict how that will happen. Classification of visual field defects from Oates study. There are 6 types: altitudinal type, arcuate type, partial arcuate, paracentral, nasal step, and temporal wedge. Before going to describe each type, I would like to discuss the vulnerability zone of the optic nerve. The temporal half of the optic disc has 2 vulnerable regions, a superior vulnerability zone and the inferior vulnerability zone. The inferior vulnerability zone overlaps the region of CPRNFL associated with inferior macular retinal zone. And the region of the overlap, this is marked with a circle, is the macular vulnerability zone. The SBZ does not overlap the region of the disc associated with superior macular retinal zone. Now come to the nasal step. A nasal step is a relative depression of one horizontal chemifield compared with the other. Now, nasal step, nasal depression at the 6 points, including the dim, that meets either the minimum criterion for the field defect with abnormal pattern standard deviation less than 5%, has no other temporal defects. So you can see here the nasal step, and also it is prominent in the grayscale. Now, please find out the site of damage. You can see here the site of damage. You can see here is already we have mentioned the vulnerability zone. So this is the site of damage, and the retinal area served by the damaged retinal nerve fibers, this area. So it's the superotemporal. So damage is, according to that, visual field is in the nasal chemifield and is the inferior nasal. We can see also in the grayscale. The nasal step is the result for this nasal tip is the result of damage to superior nerve fibers serving the superotemporal retina beyond the paracentral area. Next is the paracentral scotoma. A paracentral scotoma is an island of relative or absolute vision loss within 10 degrees of fixation. So the area of damage or the site of damage is here. You can see here is the macular vulnerability zone, and the retinal area served by the damaged retinal nerve fibers is inferotemporal. So we have the superotemporal area defect in the pattern standard deviation. You can mark this damage in the gray scale. Paracentral scotoma may be single, multiple, may occur as isolated findings, may be associated with other early defects. Next example, again, the paracentral scotoma, location of paracentral scotoma here in the superior one, and you can find is inferior nasal area, that is the paracentral scotoma. Paracentral scotoma can occur anywhere in the central visual field, but they are particularly common in the nasal field. Next, I come to the central visual field defect. Central visual field defect was non-recognized by the Oates study and classified as other patterns of visual field defects. However, glaucoma patient may present with macular damage or central visual field defect in the early disease stage. Poor detection and under-detection of central visual field defect in glaucoma suspect or patient with early glaucoma affects the quality of life severely. Detection of central visual field defect is essential in the diagnosis and management of glaucoma, even at the earliest stage. Types and patterns of central visual field defects we can see. Already we have mentioned initial parafoveal scotoma. It is situated within the central 10 degree, within the central 12 points. So here you can find the next one is the abnormal single point. P less than 1% within the centralmost 4 points. This is a type B. Abnormal central points defect in a cluster within the central 10 degree, where the cluster extends beyond the central 10 degree. You can see the C is the third type, where we can see the defects within the central 10 degree or within the central 12 points within a cluster. Because the cluster is not present here, but here the cluster is present and that cluster is beyond the central 10 degree. Now please note that in these cases, all these cases, 24-2 VFI, mean deviation and pattern standard deviation, especially the mean deviation and pattern standard deviation, are much lower than what when the eye was tested with 10-2, we can see the mean deviation and pattern standard deviation are much higher. And we can see in all these eyes the deep arcuate scotoma in the upper hemifield. So severity of this damage definitely is more clear with the 10-2 visual field. Now we have heard about scotoma in the last lecture. So please note, these are almost absolute because less than 0 decibel is here the sensitivity. And of course, in all these cases, and is the less than 0.5% is the probability plot of this spot. So these type of visual defects are dangerous because you cannot have the, patient have the reading difficulty and also the recognizing faces, and patient can't drive also if these type of defects are there. Now, Hood glaucoma report is ideal to detect this type of defect because the pattern of Hood glaucoma defect is Nistine pattern, not like the conventional OCT, what we do. Next, we come to arcuate scotoma. It occurs in an area 10 to 20 degree from fixation. Now, please note here, damage is here, and this is the retinal area sought by damaged retinal nerve fibers. So, glaucomatous damage to a nerve fiber bundle from both the inferonasal and inferotemporal retina resulted in the arcuate defect. And it begins as a single area of relative loss, gradually becomes larger, deeper, and multifocal. So in the pattern deviation, you can see the defect. Also, the defect is definitely recognized in the grayscale. Arcuate scotoma arches over the blind spot. You can see here, this is the over the blind spot and ends in the nasal raphe. So arcuate scotoma becomes wider and closer to fixation on the nasal side. So you can see it in the pattern standard deviation. Combination of superior and inferior visual field loss, such as double arcuate scotoma, may occur resulting in profound peripheral vision loss. Next comes to the altitudinal defect. This is the altitudinal defect, and this is a defect caused by NAIVN. Now, altitudinal defect with nearly complete loss of the superior visual field, characteristics of moderate to advanced glaucomatous optic neuropathy. Now, we should know the difference between the non-arteritic anterior ischemic optic neuropathy and open-angle glaucoma with altitudinal visual field defect. So almost it looks similar, so we should know how to differentiate them. Now, RNFL asymmetry is not different between the two groups. However, the inferior RNFL thickness is less in the open-angle glaucoma group than the non-arteritic anterior ischemic optic neuropathy. You can see here the inferior RNFL is definitely, thickness is less. Next is a very important topic, myopic neuropathy and related visual field defects. Myopic glaucoma is considered to be a disease composed of myopic optic neuropathy and glaucomatous optic neuropathy. Now, these defects are often difficult to clearly differentiate. This is a high myopia related defect where we can find enlarged blind spot, and here is the glaucomatous defect in a myopic eye. The mode we see in the next slide. Visual field abnormality classification in non-pathologic highly myopic eyes. Now, these type of patients may come with normal visual field, may come with glaucoma-like defects. What are they? Paracentral defect, nasal step, partial arcuate defect, arcuate defect. They may come with high myopia related defects, that is enlarged blind spot, vertical step, partial peripheral limb, non-specific defect. They may come with combined defects, that is nasal step with enlarged blind spot. So these are the visual field abnormality classification with corresponding fundus photograph. Now, frequency distribution of each visual field type in a highly myopic eyes. So already we have mentioned normal type is 74.1%, myopia related, that is enlarged blind spot 9.5%, non-specific defect 5.1%, and glaucoma-like defect, that is nasal step 3.8%, paracentral defect 2.2%. Now we come to the visual field defect in cataract and glaucoma. This patient is 80 years old and a typical cataract pattern being monitored as a glaucoma suspect. If you see the total deviation probability plot, you can see it's very noisy. However, the pattern deviation probability plot here is absolutely normal. Now, if you look at the global indices, you can see glaucoma chemiphiltries general reduction of sensitivity, VFI 99%, mean deviation is definitely high, -5 decibel, pattern standard deviation 1.33 decibel. So it's very low. So definitely is a non-glaucomatous changes or non-glaucomatous defects from the pattern standard deviation plot and from PSD. So it is only cataract is present in this case. Next patient is, we have cataract and glaucoma both. So overview report of an eye with glaucomatous visual field defect and increasing cataract. Now, if you see patients with visual field, October 18, 2016, total deviation shows both the cataract damage and glaucomatous damage. Whereas in pattern standard deviation, we can see only the damage due to glaucoma. Now, same is September 13, 2017. And after cataract operation, you can see in the total deviation plot and pattern deviation plot, the defects are almost similar. I mean, only glaucomatous defects are there. And here we can see also nasal, inferior nasal field is also involved. Now, falsely abnormal visual field. Sleepy patient, you can see already we have mentioned that we should know how to differentiate it. So this patient is sleepy and you can find this is the superior hemifield is definitely depressed. Learning effect is another point on 24-2. It typically is the peripheral test point. Already we have mentioned that variability is more common in the peripheral test points and that is somewhat depressed here. The second test was done and it also shows the only moderate improvement. Now, next is the learning effect in the next patient. You can see definitely is more noisy. After the second test, again, this is only moderate improvement. Now, non-glaucomatous visual field defects. This is a visual field defect, obviously. Now, if you look at the fundus, you can see optic nerve head drusense. So optic nerve head drusense cause this type of visual field defects, and this is non-glaucomatous. Now, you see this patient in 2018 June, normal visual field. Now, in September 19, 2018, the patient is having visual field defect. October 2018, again the same visual area, same type of visual field defect. However, in November 28, 2018, visual field again is normal. So this is a visual field defects in thyroid eye disease and disappeared after treatment. Visual field loss in retinal disease. So it's an unusually large visual field defects associated with macular degeneration. Now, visual field defects in retinal vascular occlusion, arterial occlusion is absolute defect. Small BRVO may be normal visual field defect. CRVO, profound and widespread visual field loss. Like here we can see these visual field defects is associated with laser scatter therapy in diabetic retinopathy. So we could conclude detection and documentation of abnormalities in the optic nerve should be a part of the routine clinical management of glaucoma. Detecting abnormality and documenting functional status should be part of routine clinical management of glaucoma. Both structural examination and functional testing are needed to detect and confirm the subtle early stages of the disease. Data from both functional and structural examination always should be evaluated in relation to all other clinical data. So clinical data should be added both with the structural and functional testing. Now, these are my references. This book is available, it's a Kindle one, and also that this is the, you can see paperback is also available. Excellent Perimetry is also very interesting book and very useful book. Thank you for your kind attention.
Thank you so much, ma'am. Dr. Prasanna?
We'll open it up to the panelists. Mona ma'am, your comments, ma'am.
That was an excellent presentation, and I thank you for highlighting the importance of doing 10-2, especially in early glaucoma. There may be many paracentral defects which may be missed if you don't do 10-2 and you find a 24-2 normal, but that is suspicious. So one thing I would like to suggest to the PGs and students is that please go and do your own visual field tomorrow, and then do a patient's visual field to see the challenges the patient feels and how you need to position the head, position the chin, monitor the gaze, which is very important. And only then you will be able to understand and counsel the patient whom you're advising a field test, and also being able to interpret the field test to see what all artifacts can occur because of the head going back, the lids going down, the patient falling asleep and not pressing the button. So that is one important thing. Secondly, whenever you see the printout, go, like you must have read in all the books and articles, look at it zone wise, see whether it's reliable or not, whether it belongs to that particular patient or not, and then examine the printout, because each part will give you information, separate information, which then you can collate and then clinically correlate, as Dr. Tutul said, that you need to correlate with the OCT disc and other findings, and then only make your diagnosis. So when you apply the Anderson's criteria, make sure that the most of the students, when we ask, give the 3 points. What they fail to say is the location typical of glaucoma. So when all those points are in a location typical of glaucoma, only then you would suggest that this may be a glaucomatous field. Even then you need to correlate clinically. So it is a psychophysiological test, and you have the threshold. You should know how the threshold is determined. The points are like 50% of the times the patient may not be seeing the points, which is normal, and that you need to tell to the patient, because many of them get stressed that they are not able to see the points, and they feel bad that their field is really bad, whereas that is actually a part of the test. So these are some take-home points from my side.
Thank you, ma'am. Subhashini ma'am, your comments, ma'am.
Yes. Actually, there are two aspects to fields. One is doing the test and getting a reliable field, and the other one is interpreting the field, the field report. So, doing the test, what I usually tell the optometrists and the other PGs, if they're doing the test, is to explain to the patient about the test. Mainly, the main problem is fixation. Say, and when they see a light coming from somewhere, so they have the tendency to look from where it is coming. So instead, they should be advised that they have to look at the central point only. And another thing is, patients, what they think is like the stimulus has to be of very good brightness for them to detect. So dim stimuli, they think unless they see it properly, they have to click the button. So this is another thing that you need to advise, and first the patient has to understand well. Only then we get a reliable report, and our interpretation depends on a reliable fields. So these are some points that we need to know and tell the patients. And another thing is, Dr. Tutul was telling about the Anderson's criteria. One clarification I need. So because this Anderson's criteria was meant for the central 30-2, now for all glaucoma tests, so we have moved to central 24-2. So what I would like to ask is the non-edge points which are there in the Anderson's first criteria. So that does not apply for 24-2, right? So because residents always get confused, they always think it's the non-edge points. So whether the same applies for a 24-2?
So for 24-2, you can take this, I mean, even the age points you
Edge
can take.
points.
Yeah. And number one. And number two, now I think is the time to think about, because now central visual field defect is absolutely so many researchers are going on, and it's a new visual field 24-2C is present here. And other machines, they are also trying to find out another type of visual field that can document both central and peripheral, both the defects, because it is very quite clear that 24-2 is not able to document both the types, that is central and peripheral, at the same time. And 10-2 is there to do the central visual field. But the question is, we cannot ask the patient to do both the tests in the same day, right? Because every time that patient is always tired, and it's difficult also that after so many tests, you can ask the patient to do the 10-24-2. I mean, especially the reliable, both the reliable, I mean, 24-2 and 10-2, both should be reliable. Now, the question is, we have to have one testing where we can document both 10-2 and 24-2. That is number one. And number two, even we can going to do Anderson criteria, we should remember that when we are using Anderson criteria, we are more looking for a peripheral defect, not the central one. Because central defect, even it's the central 10 degrees, central 12 points, often we miss.
Even if it does not fit the
Yeah, and it's
right.
just a dot. And if you think is the point is, because that's why we have our research on central visual field defects, that if the defects 3 times, I mean, you are getting is a normal tension glaucoma patient 3 times the same defects in the same area, both in the total deviation plot and the pattern deviation plot, you cannot ignore that. So it should be that time you have to forget about the cluster
Even if
criteria
it's a
in.
single point.
Yeah, you have to think about the central point. Another point is also there, that Anderson criteria, what they are in 24-2, so far we have done, right? That is glaucoma 3 criteria. One is the pattern standard deviation less than 5%. And the other thing is 2 other criteria is cluster criteria and glaucoma field. Even in my practice, also in my research, I have seen so many times GHT chemifield shows within normal limits, but there is a central defect, because it depends on the sensitivity. How much? If it's less than 0, only that time GHT is very, they are very reliable.
Sensitive.
They can point out that defect, that chemifield defect. But most of the, so many times they're showing borderline. So if it shows borderline, what should you do? Should I say that the visual field is normal or abnormal? This is number 2. Third is the cluster criteria. Now, if you the initial parafoveal sclerotoma, by definition, it may be 2 or it may be 3. Now, the question is, how much is the sensitivity? Sensitivity is less than 0, central 1, 2 points are there, P less than 5%, then we don't have to think about the typical cluster criteria, 3 or more, and non-age, and what would be, because that time you have to think about this is the visual field, we are looking at this visual field for 3 times or 4 times the same area, total deviation, pattern deviation, both. Then we have to think that this is not is the occurrence. This is a definite glaucomatous visual field defects. And if you look at because I think this is the way we are missing so many normal tension glaucoma patients, because these patients 38, 40 years, I don't know, I mean, whether there is any study, is in Indian study, that typical age of normal tension glaucoma patient in India, because we have seen 38, 40 years patient, typical defect, typical neuroretinal thinning is there. But because these 2 points are there or something like that, and really it is ask the patient for doing every time the test, and every time patient is not able to perform the absolute, I mean, totally reliable visual field. So we should have in our mind that we have to detect two types of defect. One is the central defect and the peripheral defect for our patient benefit, and we have to detect early glaucoma. And it is not only normal tension glaucoma. I've seen many high tension glaucoma patients, they come with earliest disease stage with central visual field defect.
Yes. So in early glaucoma, the initial manifestation, field defect could be central defects. And
Yeah, central defects.
You were
Yeah,
telling
and
one of the criteria, no? If it fits Anderson's. So generally for PG teaching, we say all the three criteria. But in
yeah,
real life scenario, we need to take it with a pinch of salt and try to understand, especially if there are central defects, we need to be very careful. And because in resident learning, always the eyes have the tendency to only look at the grayscale. If the grayscale is looking normal, they think there is no field defect and it's labeled as a normal fields. So we need to look at the pattern deviation plot and look for those central points if they're affected or not. Correct, ma'am?
that is what you say is a very important thing, that we always think about the grayscale. I mean, because typically all early glaucomatous lesions, they come and vary, right? Fluctuation is the key point. I mean, they are never stable for, I mean, even 2 years it will take to come to a stable glaucomatous visual field defect in whichever chemifield. Now, in by that time, in grayscale shows nothing. So we have to see for the pattern deviation and total deviation plot. Now, if the total deviation and pattern deviation, just I have shown the same type of defect, I mean, you should, I mean, they residents should be, I mean, curious to know or suspicious what is happening, and then they will match with the grayscale. But normally grayscale always comes later. First is the pattern deviation and total deviation. Even in some investigators now, they depend on the total deviation also. False positivity chances are much more, I understand. But even the for early detection, if the patient has no cataract, but that total deviation plot is always noisy, and pattern deviation is there but not that. So I mean, better to go GCIPL and macular things for OCT to identify any earliest defects are there or not, so which we are missing.
I just want to ask, if you see some field defect on 24-2C, do you go ahead and do a 10-2?
No, is the question is 24-2C or 24-2?
24-2C. You see some
Yeah.
defects in the center. So do you want to confirm it by doing a 10-2 then?
Actually, we have done our study comparing the 10-2 and 24-2C. So that time we, during my fellowship in Fulbright in Hamilton Glaucoma Center, so that time we found that 24-2 and 10-2, I mean, both of them are competent, right? Than the 24-2C. Because the question is the points, the way the points are placed in 24-2C and the way they are placed in 24-2 and 10-2, they're all linear. I mean, the vertical and horizontal. But in 24-2C, they are curving, right? I mean,
Between
so
the 2 points.
yeah, between the two. So if they, I mean, we have seen that visual fields are there, but when we are comparing with the OCT, OCT didn't recognize that field defects. So I think is 24-2 is definitely good. You can go for screening, but you are right that if we find this on the 24-2C, I can say it's a screening test, I will go for 10-2. to be confirmed. Even I will go for 24-2 also. Just because I just don't want to miss, because in glaucoma, the most important thing is not mix. The most important thing is early detection. So I just don't want to miss its single chance to, wrong diagnosis or late diagnosis, because you know how difficult to convince the patient that they don't believe because of this, at the vision is 6/6, even at the, double arcuate scotoma. So they cannot believe that they can't see. So that's why it's better to be very particular about to diagnose the case as early as possible.
Thank you, ma'am.
Thank you, ma'am. Swati ma'am, over to you for your comments.
Ma'am, very extensively covered presentation, ma'am. Thank you. Ma'am, my question is, where do you see the macular split, in the pattern deviation plot or in the actual retinal sensitivity values? When do you say there is a macular split?
I can do macular visual field and then can ask the patient that I can show the patient that this is a defect is there.
No, ma'am. So if you go by the real threshold values, if there is only 10-2, patient is not able to do macula, and I'm going to take the patient for surgery, when do I call it a macular split?
So, you can see, the 10-2, in the central visual field, you can see the split is there. So, that we can identify.
Real
Take a
value.
p-value less than 0 in any one of the quadrants in 10-2. You should not tell in 24-2. Split fixation, you
ma'am.
comment
Yes,
only on 10-2.
Yeah, it's only on
P-value less than
10-2.
0 in any of the
That's only,
quadrants.
ma'am.
The central 4 points, one of them
Central
is
4 points.
Yeah, so I used to go by this, but one of my colleagues is of the view that the real threshold value, which comes in the values 0, 9, if they are 0, 0, then only you call it a macular split. So I used to go by the pattern deviation plot, where I used to see the probability p values, right? But so my question is whether to go by the real threshold values or by the pattern deviation center 4 points.
For me, I think it's better to go by threshold value and p-value both, right? Because threshold value gives a real life, because real picture. And when you are going to, first of all, it is true that patient can, macular split is there, and in the end stage glaucoma, there is a risk of wipeout thing. So you should be doubly sure that what you are going to do. Right. So I think it's better to be very sure before going to take the patient for surgery that is a central 4 point is a 0 decibel, and whether what is the p value also, that, and it's always is a central is less than 0 decibel, always the p value will be less than 0.5%.
So ma'am, if none of the values are 0, if it is like 2, 5, 4, 8, do you still call a macular split?
No, but if the
Threatened
p value is
fixation.
there,
It's called
if the p
threatened
value is
fixation,
there,
if I remember.
pardon?
It's called threatened fixation. But
Threatened
not
fixation.
Only if you
when it's
take
2,
0,
5, the
the
values are
actual
2,
value,
5,
not the p-value.
like that. But if it is 0, then you call it a
Call
split
it a macular
fixation.
split.
Hmm.
Yeah,
Yeah.
only like most of the studies will do that. They'll take the actual threshold value as 0.
One last.
I think
Yes,
even
ma'am.
if, sorry.
No, ma'am, yes, ma'am, go ahead.
I think it's better we should, for glaucoma, those who are really doing glaucoma patients, dealing glaucoma patients, I think for even an OCT or the visual field, what we do, we should go to the basics. Because we are diagnosing case. So I think threshold value and p value, both if we take, we consider, I think our diagnosis will be better. That is my understanding.
Thank you, ma'am. Ma'am, one last comment, Prasanna, last comment.
Yes,
That
ma'am.
there is a paper by Dr. Jitin Yohanan, which says that fixation losses, I would just like to share this paper, that this fixation loss has little impact on reliability in patients with established glaucoma. False positive and to a lesser extent false negatives and total deviation significantly affect reliability. So the PGs normally when they say fixation losses XX, they just straight away write unreliable fields, just based upon the fixation losses. So fixation losses can be there, but you should go for the reliability based on false positive and false negatives. Just not disregard the fields just because there are high fixation losses.
And the gaze tracker is also important. That actually shows what how the
Patient is
patient
actually
has moved
doing.
the eye. That is more reliable because it's real time also.
The thing is, false negative is very tricky because when we say the patient is having false negative, in all moderate glaucoma, I mean, moderately moderate glaucoma, not in the -7 decibel dB or thing, I mean, those who are close to -12 and after 12, 15 or 16, till the, I mean, 20 like that. False negative is too much and it's not the patient's fault. And it's because really it's very difficult that in these type of patients to do visual field because false negative will be there because a patient can't discriminate, right? And because the total deviation value and pattern deviation value that time are confusing and that time, so we don't get the real picture. So false negative is 20% or 50%. I have seen 50% false negative. The test is definitely unreliable. In that case, I really don't know how to do that. Only the 10-2 we can do and to know the actual how much is the visual field remains. So this is really difficult to understand because false negative will be more any advanced stage glaucoma.
Advanced glaucoma.
Yeah. So, but false positive we can control to make the patient understand, and same is the fixation. Both can be controlled. We can explain the patient that you have to look here, and after 2-3 tests, I think patient can learn that. But really difficult thing is the false negative one because this is not the patient's fault. It's not the learning curve. It's definitely patient's, I mean, inability to make it good visual field. So that time we have to take 10-2 test and we have to use our experience.
Yes, yes,
And
ma'am.
most important thing, we should not allow the patient to go to that stage.
Thank you.
Yeah, just a point for the residents. Of all the 3 reliability criteria, the false positive is the most important. So need not give much importance for false negative. So that's why even in 24-2C, we do not have the false negative catch trial.
Thank you.
Thank you, ma'am, for all your inputs. We had good learning. Even we also learned a lot from your presentation.
Yeah, thank you. And the most important thing is nowadays the myopic patients. And
yes, ma'am.
Soon we'll get more myopic patients and myopic patients with visual field defects, and even all the time we are just struggling how to differentiate it with the real myopia, myopic glaucoma, and this only myopic defects only, because enlarged blind spot, when there's a scotoma due to, I mean, paracentral scotoma and with a nasal step and the myopic patient and with some enlarged blind spot is really a mess, because we really don't know, I mean, what type of glaucoma, I mean, whether the patient is really glaucomatous or is just a myopia, and what to treat and not to treat.
Thank you. Thank you, ma'am. Thanks to all the panelists. And handing it over back to my co-moderator Sunandini for the closing vote of thanks. Sunandini, over to you.
Thank you so much, Dr. Prasanna. We are very enlightened today in this Sunday afternoon, where we have learned so much from our speakers, Dr. Shalini Mohan ma'am, Dr. Anindya Anuradha ma'am, Dr. Pooja Bang ma'am, and Dr. Atul Chakravarti ma'am. And we are extremely thankful to our esteemed panelists, Dr. Devantuli sir, Dr. Devendra Sood sir, Dr. Mona Khurana ma'am, Dr. Subhashini ma'am, and Dr. Swati ma'am. And I'm very thankful for AIS for giving us this opportunity today. And I'm very sure that the resident have learned a lot, as so as me and Dr. Prasanna also have learned a lot today. And with this, we are concluding the session. Thank you, everybody, for a patient listening.
Thank you, everyone.
Thank you so much, ma'am.
Thank
you.
Bye, ma'am.
Thanks a lot.
Thank you,
Thank you
ma'am.
so much, ma'am. Thank you.
Thank you.
Thank you.
Thank you, ma'am.
Thank you so much, ma'am. It was really, I'm not a cornea, I'm not a glaucoma specialist, but today I have also learned a lot, ma'am.
I have also learned a lot.
Thank you so much. Thank you so much.
Hi, Mona.
Have a nice Sunday.
Yeah, same to you, Mana.